Get started so we can get this ball rolling. Our first speaker is Dr. George Wham, and he is head athletic trainer at Gilead High School. He's been a consultant with us in our grant and has really helped direct us in the right ways to provide our training to school staff. So let me go ahead and introduce Dr. George Wham. Thank you.
I got talking pretty loud, so I could probably do this without a speaker, but we'll try to make use of it. Guys, let's take a little show of hands here and see what our audience is like. I know there are athletic trainers here. I know a lot of familiar faces. I know there are school nurses here. I know there are coaches here, but let's do a little, by show of hands, a little breakdown. If you're an athletic trainer, raise your hand really tall. All right. I hope what I tell you today is, hey, I got my 3 CUs and I didn't learn anything because I'm already doing it all. And maybe you're even doing it better. And maybe even you can share some things with the group that of how you've implemented some things. So this information, I hope, isn't that new to you. Raise your hand if you are a coach or AD. Okay? The information you're going to see today, and my talk really is going to focus really on 3 parts. Why we need to know, about concussion. What's new about concussion, why concussion is important. We're going to look at some of the regulations regarding concussion in terms of what are the standards, what are the guidelines. We're going to look at some of the bills that are out there that may pass into law. We're going to look at some of the rules out there in regard to the high school league and some of the new stuff they've done. We're going to look at some things that have been done outside our state that might give us some direction. And then lastly, I'm going to share with you some of the things we've done at our place to implement. What is the plan at our place? Understand that our plan is a living document. We are looking to do it better every day. As new information comes out, or we see somebody that's doing something innovative. And I hope I will learn some things today from some of our other speakers. I'm giving you the high school perspective today. I think that for us, we provide service for our high school and middle school. So really, if you're from a middle school today, soak it in and use your personnel and resources. And that really goes for everybody. You use your personnel and resources to implement these things as you can. What you're going to find is a lot of these things, some of these things cost money. Some of these things are just knowing to do it and knowing where to get it and knowing how to implement it at your place. So we got some coaches here today. School nurses, raise your hand. A lot of school nurses, that's good. How many of you are at middle school? How many of you at high school? Okay. You guys are likely to see these kids walk in and say, I had a headache and I got hit last night at basketball practice, or maybe it was at home. And guys, the title of my talk today is It's Not Just a Headache. Because I can't tell you how many times a kid comes in or a coach doesn't understand, or a parent doesn't understand. People have headaches for all kinds of reasons. I understand that. But guys, with the modern definition of concussion, you gotta understand it's not just a headache. A lot of times there's things that are there, you have to know how to dig. And I'm going to try to give you some tools today and some info today that will help you to learn how to dig. How do you make sure that you're following the guidelines that you should? How do you have things in place? I have personnel, if you notice, they didn't really have personnel on site to deal with it. They just have to be fortunate enough to have a doctor, the stands, and EMS worker on the chain crew or something, referees. Guys, these people, if you continue to watch the rest of it, mom and dad don't blame anybody. And that's kind of refreshing in a situation where people are quick to blame. The doctor feels really bad about it because, one of his patients died and he was a part of that. The coaches feel really bad because they feel like they didn't do everything they could. And I guess I would say, they did the minimally, you would say what was minimum, the general public would probably say what was minimally appropriate. They sent him to the doctor, they held him out. As soon as they identified symptoms, they referred him along. But guys, we can do so much more. And so today, the focus of my talk is giving you some of those tools so that you can do it, and so that at least you know where to go look, because this stuff is always changing. So you got to stay on top of it. What you learn today is going to evolve tomorrow and the next day. Note between January, and I need to update this slide, I've done probably 7 or 8 of these talks and did a number of them through the summertime. But just during the period last year, second semester, if you want to call it that from a school standpoint, there were 84 published studies. These aren't little articles in the newspaper. We're talking about published studies during that time. This is a hot topic. I'm sure if we ran it through the end of the year, you'd probably wind up with 150 of them, because this is a hot topic that's being researched. So much is being learned all the time. And that new knowledge helps guys practice. Here's a study that I think helps us get a grasp of this in a high school setting. This was a study that was done over 25 schools in over 11 years. So you're looking at 25 schools over 11 years, and what they saw was that there were about 2,600 concussions with about 11 million exposures. The exposure is a chance. The chance doesn't have to be one practice. So you got 100 players go out to practice, you had 100 exposures that day. Okay, so 2,600 concussions and about 11 million exposures. Concussion rate increased during that time 4.2% over the 11 years. That's a 15% annual increase. Why? Why do you think concussions increased? Well, could it be the way that we're participating? Perhaps. I would say, though, I think people, our definition of concussion has changed. I was giving a talk some years ago, and we were talking concussion, and this was a physician stood up and basically told me that if you weren't not unconscious, you didn't have a concussion. I'm afraid for his patients. Okay? That is a very old school way to look at concussion. I think part of the reason for this increase, maybe the way, maybe more kids participate. Okay? But I think a big part of it is we changed the definition for what is a concussion because our understanding of what a concussion is different than it was years ago. I also think, especially recently, if you're at a school, if you're an athletic trainer, I can almost guarantee you saw a lot more concussions this year than you did the year before. And last year, you saw a lot more than you did before because the awareness has been raised. We saw last year, and I'd have to look at it for this year, and again, Julie Sandy can tell us the best because she's at more clinics, concussion center. We had 19 concussions in athletics last year. This year, we're probably approaching that right now. Okay, again, that's our middle school and high school. And these aren't kids that are it's something terrible and there's some incident. These are kids that walk into your office and tell you the story, and you start to break it down and you find what you got. These are kids that 3 years ago we were missing. Sometimes these kids come in and I'm like, oh no, I don't want you to have a concussion. I want you not to have a concussion. But when you start breaking it down and you start looking at it through the modern eyes of concussion, that's what they had. And I won't say it makes you feel good, but at least you go when that thing hangs around and you discover some other things going on there, at least it goes back and kind of verifies that initial feeling you had. They came and reported this to me, and it was the tip of the iceberg. So anyway, increase in concussion. Football accounted for half of it. I mean, let's be honest. You got a sport where the whole idea is to smash the other person. It's a good thing we don't have boxing in South Carolina high schools. I mean that's a whole sport that's concuss your opponent into submission. Lacrosse. We do have lacrosse picking up here. If you look at this study, the number 2 was lacrosse. And what's the biggest growing sport in our state right now? Lacrosse. They're adding, a few schools are adding it every year. So, if you're a school with lacrosse, expect to be seeing some concussions and wonder why you aren't seeing it if you're not. I would say this: if you went through a football season and you only had 1 or 2 concussions, I don't think you look at that and say, oh, we were good, we didn't have many concussions this year. I think you look at that and say, we didn't catch many concussions this year. And I think you need to think about lacrosse. Look, girls soccer. We impact tested our girls soccer, and we'll talk about impact testing in a little bit, but it's a computer-based neurocognitive test. Very helpful. Not the end all, but very helpful. And I taught the speech I gave before we went in there, I said, guys, you are the highest risk girls in this school for concussion. You need to take this test seriously, and we went through the whole 9 yards of why it was a big deal. But girls soccer, top of the list as far as girls sports go. Girls are twice as likely to suffer concussion in similar sports, says this study. Now, is that because girls are more likely to report it, or does it actually happen at a higher rate? My hypothesis would be they're more likely to report it, because girls, women in general, are more likely to report issues with their health than men. That's like a public health, and that's not just for concussion. Startling numbers. What you have to understand is the mindset of an athlete. When you talk concussion, you're not talking about an ankle that's a big swollen black little ankle that's limping, and everybody goes, ooh, that's awful. You better get some help for that. You're talking about something that's easy to hide. So let's look at this and get an idea of why are concussions underreported. High school football, 66% didn't think it's serious enough. It's just a headache, or it's just a little dizziness. It happens all the time. I just got my bell rung. They didn't want to leave the game. They didn't know it was a concussion. They didn't understand what a modern definition of concussion was. They did not want to let their teammates down. Guys, in sports, you're taught to be tough. You're taught to get in there and go and push. And that's a good trait for a lot of things. This is not one of those areas that you want to get in there and push through. College football facts. Look at this. I would expect the same sort of numbers to be present in high school. 6.3% of players suffered concussions as observed by the athletic trainer. That means of the 100 players on his team, 6% of them had a concussion. That's what they observed. The athletic trainer identified. They came to him and they treated him. But if you look at this, 70% of players reporting concussion-like symptoms anonymously in a survey after the season. So does that tell you you're missing an awful lot of them? And then you look down here, here's the startling fact, these guys that play long enough. 1 in 1,000 chance that a 30 to 49-year-old man will receive a diagnosis of dementia, Alzheimer's, or another neural-related disease. 1 in 53 for a guy who plays in the NFL. Okay? So you got to think about the cumulative effect of all those blows over all those years and what it gets you. And, you know, we read the newspaper and we see stories on them all the time of the, I guess, what the toll it takes on those guys' body. So let's look at the trend a little bit. Again, why is concussion important? Well, it seems to be on the rise. If we go back and look at when they instituted wearing the modern helmets, what was it designed to prevent? It was designed to prevent concussion, skull fractures. And it does a good job of preventing skull fractures. But if you kind of follow the trends, it kind of goes up, and then we changed the rules in the early 70s in terms of the way that's, I guess, modernizing the helmet, changing the rules. You started to see it come down in the 70s and 80s and 90s. But then if you look at the bottom, you're going to look at Mueller. It's interesting to look at that national database of catastrophic injury that they maintain there at UNC. 18 deaths between 2008 and 2009 alone. Between 2005 and 2009, there were 39 fatalities, more than any other 5-year period since Mueller, which he started about 1980 or late 70s, began collecting data. So we see a problem that's increasing. Now that's not just the reporting of concussion. We're talking about the catastrophic ending to these things. Why? So where, you know, there's the kind of a lead-in about concussion, why it's important and why we need to pay attention to it. The consensus statement released, it was actually released in 2009. The meeting took place late in 2008. These guidelines came out spring of 2009, around April and May. Okay? It is the gold standard. This is, if you say, what should we be doing? What is the current knowledge? What is modern? What is our modern understanding of concussion? Is found in this paper. It's an international consensus statement of the leaders in the concussion area getting together and deciding this is what we need to be doing. They came up with, of course, the paper that tells you, they also came up with a SCAT-2 document. We'll tell you more about SCAT-2. How many of you are using a SCAT-2 right now in your program? I would encourage, if you're saying, no, we're using SAC, well, guess what, guys? The SAC is part of the SCAT-2. If you look at it, it's broken into little pieces. SAC is part of it. The BEST, or a modified part of the BEST, is part of it. But it's a way to quantify concussion on 100. Out of 100. Okay, what are you? Normally, we would expect most of us right now, if we were to take this, to be at least in the upper 90s. We may not be 100. Because there is some things that we might struggle with. But anyway, we'll talk more about this. But that SCAT-2 is a form that you need to be using. And you need to, if you haven't updated what you do, it's something I put in your packet today. I hope it's in the packet. I sent it to you. So let's step back and talk through. First off, you have to think, we are dealing with a child and adolescent population, and that athlete is different. That athlete is different than that NFL athlete or that college athlete because their brain is still developing. So you have to consider specific physical and cognitive rest issues. You have to consider that symptoms will take longer in our kids than they will for the college kids or for the adults that sustain similar injuries. Consider extending the symptom-free period before starting return to play protocol. So, once they're asymptomatic, should you hold them out longer? We're going to talk about that and at least show you what we're doing in our place. Consider extending the length of the graded exertion protocol. Guys, if there's one thing that I would say I would like to see included in our, whatever bill gets passed into law, is a requirement of a graded or a graduated return to play. Too often I'll get a note from an ER doc or from a family doc or a neurologist, that's the scary one, that says he was concussed, he may return to play. With not requiring a graduated return to play, that is a day of increasing level of intensity to see if symptoms return. Yesterday you were concussed, today you're not, you go back. That is not how it should be done now. So with our kids more than the colleges, the pro guys, that's an important piece of this puzzle. The last bullet, no same-day return to play. If you're going by the American Academy of Neurology guidelines, which is what we used before these guys came out, when could you return a kid to play? If the symptoms lasted for less than 15 minutes on the sideline, you could put it back in. And that's what I did. I was following the rules. But under this definition, as of 2009, no same-day return to play if they have any symptoms of concussion. Any symptoms of concussion. And that can get kind of hairy. and determining, okay, is this concussion or is it not? And that's why some of these tools, again, are helpful. You know, it's better to err on the side of caution when you look at the potential for catastrophic injury. Sports concussion, follow-up management. The key here is rest, 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 rest. This is not a rehab thing, at least as we understand it now. I understand there's some potential for vestibular training and some things like that, but at least as we understand it now, and for most of us, it's a rest thing. And when we say rest, we don't just mean don't practice. We may mean, you know, limit what you do in school. We may lay off the gaming and texting. We may say, you know, let your mind have rest. Expect a gradual resolution in 7 to 10 days. And then after that resolution occurs, after those symptoms go away, you start that graded exercise program. And I'll show you what that looks like for us. Guys, these aren't, I didn't even make this slide. See that little blue part? That's right out of Zurich. So this isn't my interpretation. This is literally what they're telling us. Understand, the cornerstone in management is rest. Rest until asymptomatic. Rest from activity. That means no practice, no lifting, no running. Cognitive rest. What do you do with school? Well, in some cases you may need to modify what's going on in school. Or not even need to be there altogether. This injury, more than any other, affects the classroom. I mean, think about it. This is your brain. The kid can have a torn ACL, and he can go sit in the classroom. If his pain you can manage the pain. But if he can't sit there and think, I can read the question, then read the 4 answers, and then I forgot the question. You know, this is an issue that affects the classroom more than most. All right, I read a couple of years ago. I read a local athlete was concussed, went to the ER afterwards, and this was the coach giving the explanation. And he's fine because he got a CT scan, and it showed everything was great. What does a CT scan or MRI show? It shows physical changes. It does not show concussion. It shows that there's a bleed, okay, but it does not show concussion. So don't say he got a clean CT scan or MRI, and therefore he's good to go. There's potential down the road for some types of MRI that might be helpful in showing some things about concussion. But right now, it does nothing. X-ray, CT scan, MRI, again, contributes little to concussion evaluation other than rule out a bleed. And that can be helpful too if you think a bleed is going on. The recommendations for Zurich apply down to 10, age 10. For most of us, that covers our population. Okay, you figure if you're in the 7th grade playing high school sports, then that's, you probably won't be older than 10 years old. Below 10 years old, again, that's where Zurich, hopefully when they come out with something next time, may have some insight for us. But fortunately, that's not what I deal with, so it's not really focused on top. We're middle school, high school, secondary students today. But recognize that is kind of a frontier here. And some of their recommendations may not be a good fit. Something we need to do, and this is something we haven't always done in our place, and we've started a couple of years ago, and that is including that teacher as a part of the care team, if you will. Making sure they understand what's going on. You'll see the email I send out, some of the stuff I send them, so that they understand Johnny's not being difficult today, putting his head on his desk. Johnny's not being argumentative or lazy or sorry. He's got something going on here that truly is affecting his learning in class. We'll talk about neuropsych testing and how that's helpful and plays a role. Regulate yourself for other equipment. What I'm about to show you are essentially standards and guidelines of how concussion might be regulated. We're going to look at what high school league's done. We're going to look at what SCATA, State Athletic Trainers Association, has recommended that schools do. Not a requirement, but it's a recommendation. We're also going to look at some of the laws or bills that are pending that may become laws. You can see that legislation has been passed / is pending in 44 states. Guys, I look at that. I have not updated that since probably early first semester. I guess it would not shock me if that number is higher now. Okay, so most states are looking at this or have passed this. So what are we doing in South Carolina right now? Well, this thing started in 2010, 2011 when the National Federation of High School Associations put these two things in place. Number one, it said that all coaches must take the concussion course. That's about a 20-minute training session. At that time, a lot of the high school league was kind of telling us that it would be kind of a one-time thing. You're going to see that really needs to be done every year. And while it seems redundant, that's what they recommended. Then the second part of this deals with kind of what do you do when you suspect an athlete has been concussed. says, under the new rule, a player who shows signs or symptoms of behavior associated with concussion must be removed from the game, shall not be cleared to return until cleared by a healthcare professional training in concussion management. That's an important sort of phrase there, because everybody is not necessarily the appropriate person to be conducting that assessment. Officials must remove the player who shows any signs of a concussion, includes loss of consciousness, headache, dizziness, confusion, balance problems, etc. So this is really putting it on the referees and the schools in terms of here's, you need to get something in place. Given the vast majority of concussions do not include loss of consciousness, but that athletes have been shown show obvious evidence of concussion, the medical advisory committee strongly believes that officials, again, this would be the referees, must continue to be empowered to remove these athletes, thus protect them from further injury. Their job is to remove them. It's up to the school to decide when they go back in. Were they concussed? If they weren't, they go back in. So what does that tell you? You need to have somebody on the sideline who can make that determination. And if you don't, then you probably need to sit them out. And that's where, again, the school needs to come up with a policy that says how they're going to handle that. But that from an official standpoint, from a referee standpoint, they have that role. This year, the high school league added a little something to it. This came out on June the 2nd, when some people were already out of school in a memo. And we weren't out of school, but we went about another week. But it says that all coaches must take the concussion course every year. You have to print off the little certificate, and then the AD or principal are kind of responsible for keeping up with it. I'm responsible at our place for keeping up with it. The coach just basically saves it and emails it to me usually when he's finished. That's an every year thing. That was not when it was first presented the way that it was, it was going to kind of be a one-time thing. Evaluation by appropriate healthcare professional before a return to play for athletes who show signs and symptoms of concussion. Those are the 6 providers who can identify whether a concussion occurred on the sideline and whether the kid should go back in or whether he should be removed and further evaluated. There is no same-day return to play for concussed athletes. So if you're decided to, when I saw, who saw the Colt McCoy deal this year? Colt McCoy gets rocked. He goes over to the sideline. I guess you hear later they were looking at his hand, and the athletic trainers and the docs on the sideline were kind of distracted looking at somebody else. But he goes back in a play or two later. I can remember watching that game going, come on now. Really? He's going back in? After that? You could see him after the game. He played the rest of the game. You could see the bright lights were really, he was a concussed individual. He was a poster boy for why, what a concussion looks like, and the fact that they put it back in was startling. Similar situation with the Baylor guy this year, if you remember. I couldn't believe they put him back in for a play or two. Now, they did take him out. Even then, the fact they put him back in, there is no same-day return to play. Concussed athletes must be cleared by MD or DO. So currently under the South Carolina High School League, those other 6 providers can't clear you for return to play if you've been concussed. It's got to be an MD or DO. Again, how many of you guys knew this and have been following this year? I can tell you, when I shared this with the South Carolina Athletic Trainers Association this summer, a lot of people hadn't heard of that because when it was released and how it was released, it didn't get the word out real well. But this changes some things in the way we've done business, even if we've been doing some things the right way. The law that kind of started things was this law in Washington. I said 44 states right now either have legislation or are working on legislation, our state included. There are 2 bills in South Carolina that really have pieces of this concussion legislation. There's also a federal bill, and that to say. But essentially it has 4 main parts, or 5 parts here. The last one really doesn't apply to us so much. Athletes who are suspected of a concussion must be removed from play. Well, our state association's already taken care of that. That's a good thing. You should have been doing that already if you're following through. That you have to develop policies and information on educating coaches, athletes, parents about the nature and risk of concussion, including the danger of return to play after concussion pending. Last year, the NCAA required their schools to have athletes sign off that they had been educated on concussion. We started doing that this year at our place. In our packet, when we send the physical packet home, there's essentially we're using the NCAA form of saying, here's information about concussion. Then mom signs off that they've been educated. So you can't say we didn't educate you, and that you have an acknowledgement of risk and a responsibility to report symptoms. Again, we're just doing what the NCAA has told their schools to do. This law has kind of incorporated those ideas in. All student athletes, parents, guardians, sign a piece of paper, that's the information sheet about concussion that I mentioned before. Youth athletes who have been removed must receive written medical clearance from a licensed healthcare provider trained in evaluation and management of concussion. Those are the components of their law. The hardest part of this is developing those information policies and procedures on how you're going to handle concussion. That's the part that most of these other things you should be doing already, but sitting down and figuring out, okay, how are we going to address all these issues at our place is something you need to do, and you need to put it right. Here's one of the bills that's pending right here in South Carolina. There are two. One is Senator Fair, and then one is Representative McCoy from the Low Country. This is McCoy's bill. This is the original bill. Now, if you take a look and say, the Department of Education, well, I'll tell you, Fair's bill removes the Department of Education there. And if you're asking me, I think that's a good thing. The South Carolina Department of Education really isn't involved in athletics, and it isn't involved in the health and safety of athletes in South Carolina. So what he really did was take it, because that's what Virginia does. He took Virginia's bill and kind of copied it over to South Carolina, not recognizing the Department of Ed really doesn't play a role there. So that being said, Fair's bill removed that, but it basically puts the onus on the school. That's the key difference. To develop and distribute model policies concerning the nature and risk of concussion sustained by athletes. So what should that policy look like? You have to start sitting down and say, okay, what should be the pieces of this policy? Second, it requires each local school district to develop its own policy. So again, the bill was saying the Department of Ed has to help the school districts do it. Fair's bill has removed the Department of Ed from that and just said the school must come up with this. To require the removal from play and medical evaluation for student athlete that leads to sustained a concussion. Again, that's good. This law, if this bill were to pass, but it's already in the guidelines in terms of high school league list. And to allow the evaluation to be undertaken by a volunteer healthcare provider. This is just the fact that a lot of times on the sideline, you don't have a team doc who's just a country doc who lives in the community who comes out and stands on the sideline. It kind of helps absolve him of some of the responsibility that goes with serving that capacity. So the big thing here is you got to develop policies for your program. So last year, we got together at the request of the high school league, and they elected not to adopt these, but they're still there and they're still good. And we still think they will be a helpful guide for you in developing them for your school. But the South Carolina Athletic Trainers Association got together some policies on concussion in the student athlete. It provides a framework rooted in the standards, but it allows you to work out the specifics based on your personnel and your resources, recognizing that things are not the same everywhere in our state in terms of resources and personnel. These are modeled after the Virginia guidelines. South Carolina Medical Association and the Brain Injury Association both had input on these, and they are consistent with the standards that are out there. So what are they? Number one, all schools must develop a concussion management plan. You got to have some parent and athlete education every year. How are you going to do that in your place? Might be showing them a video. Might be having them read a piece of paper to sign that they've been educated. Might be through a meeting or some kind of training. Appropriate evaluation by a healthcare provider. You got to decide what healthcare providers are in your community and are willing to work with your program and how you're going to do it. Written medical clearance. That way there's no question when little Johnny's ready to come back, here's the piece of paper that says he's cleared for participation, or here are the circumstances under which he might be cleared. For us, that's going to sometimes look like, okay, he's got to go through the graduated return to play, and if he completes this, then he's cleared. Healthcare provider must use a standardized concussion assessment instrument. For us, that's the SCAT-2. We also make use of impact testing. Policy must be reviewed annually. Why do you need to review it every year? Because new things pop up. There may be better ways to do things. Again, the return to play protocol, that is what they have to do to go back, based on Missouri and American Academy of Pediatrics recommendations. There is no same-day return to play. The following conditions must be met. They must be asymptomatic at rest and exertion. How do you determine if they're asymptomatic at exertion? Well, you've got to exert them. You've got to exert them over a series of days with increasing intensity. That's what a graduated return to play protocol is. It's let's get you on the bike the first day and have you do a light job. Did symptoms come back? Okay, good. They come back tomorrow, and we're going to do some heavy running, some sprinting, some cutting, some drills like that. Do symptoms come back today? If they don't come back today, then, well, now we're sending them to our doc after that day for a final clearance. But the next day, you would say, okay, come back and do a light practice, a non-contact practice. And then the next day, a full contact practice. So for the football coach who says, I want him back today because he got cleared today, that doesn't work here. You got to insert him. You got to have a graduated return to play. Written release from the healthcare provider, as we said. Again, that one there's no question. Another piece of this puzzle is the helmet. There's another video I'll show you some of the talks have done. Kid's helmet was made in 1981. And this was probably the video we shot in like 2010. He died. You know, he had a helmet that was 30 years old. Helmets should not be out there 30 years. You know, and again, some of the industry has kind of taken care of some of this, and that Rydell's always said 10 years and I'll be retired. Now Nazi, I think, is saying you got to take it off after kids. But again, that's the thought there, that you have to have a recondition in accordance with those standards, and that you have annual training, and it must be documented. So that's our recommendations. That's what we think you ought to be doing. The federal concussion bill, again, I've heard folks say this probably isn't going to pass. I guess we'll see. But here's the thing, even if it doesn't pass, look at it because they're all things you ought to be doing. Do it because it's right. Don't do it because it's the law. You don't have to do it because it's the law. Ties the requirement to federal funding. So if it were to pass, just like everything else the federal government does, it ties it to money. So if you don't do what they say, they don't give you the money. Has parts regarding the education of students, parents, and schools, supports for students recovering from a concussion, and it has things in place for best practices designed for to ensure the uniformity of safety standards, treatment, and management. So you're going to see a lot of the same things that we've already talked about. But, you know, federal government gets involved and it gets a little more complicated. Requires elementary schools and secondary schools to post on school grounds and make publicly available on the school website information on concussions, information on risk, responses, and symptoms and effects. Requires public school personnel, if they think they've been concussed, you got to pull them out and send them to an appropriate health care provider. Report, you got to make sure mom and dad know. Now, you might think that's a kind of a common sense thing with any significant injury, but this would make it a law. The way when we have a concussion in our place, you know, that's one of those certainly you call mom and you get them in the office and you tell them what's going on, you tell them the assessment you've done so that they understand that. But then there's a sheet on the back of the SCAT-2 assessment. Some people make their own, but the SCAT-2, if you look at the last page of it, has a nice education page for parents of what to do if this happens, kind of page for parents. That's what we need. And we give them a copy of the SCAT-2 assessment for their child too, so they can take it with them when they go to the doctor. Prohibits a student who has sustained a concussion from resuming. Notice it says school-sponsored athletic or academic activities until the school receives a written release from the healthcare professional. If there's one thing the federal bill has that the state bill doesn't have, and that really we didn't even include in the recommendations from SCATA, is the classroom component. And I think we need to include that. I think as we look at this big picture, we recognize that that's a piece of this puzzle, of including the teachers and the guidance counselors and other folks involved in the school day. So it states the student is capable of resuming participation, and it comes up with a plan, because especially for the classroom, maybe he can do this, but he doesn't need to be on the computer. And our folks at Moore Clinic have come up with a nice, what do they call it, concussion learning plan. And it essentially is almost like a checklist of things, that recommendations and restrictions, things that the kids shouldn't do in the classroom while they're concussed. This is our plan. It's in your packet. It should be in your packet. You see it? I'm not saying it's the end all. I'm just saying it's what we're doing. And we're looking to do it better all the time. We have included most of the things that are in the bills, most of the things that are in the SCATA recommendations, into our one-page document of how we're going to do it. So I encourage you to take a look at that. Ask questions. Come up with something that works at your school that's founded on the same sorts of things, even if it's not doing it the same way. Again, you need to educate and have something where parents acknowledge risk. You notice this statement here. This is on a form that we have kids fill out. It's there with their treatment to get consent to get treatment, their emergency information, their insurance information. We just included a little section that says acknowledgement of duty to report injury. We include this handout from the ACA in our packet. And when I was doing this, I decided, hey, let's throw something in there about heat. Let's throw something in there about MRSA. Let's throw something in there about proper tackling techniques for football. And so they can say, hey, we've been educated on all these things. So I try to take a step back from concussion and say, what are the other things that are likely to have a catastrophic event? And then on the same side, get us in the newspaper in a very negative way, or you know, somebody can come back and say you didn't do something maybe you could have done to prevent this issue. So, but we are putting something on the parent and on the athlete, because if they don't tell us, a lot of times we don't know. This is the NCAA video. I'm not going to show it to you, but I do think it's an outstanding reference. If you know, a lot of times we show all our wrestlers on MRSA video, because, you know, skin injuries, skin infections in wrestling are such an issue, it can be such an issue, and certainly in states with an MRSA infection or even greater than most of the other things. So we take the time to show them a video. We do that in football as well. I could see incorporating this kind of awareness video into some of the things you do to educate your athletes, perhaps educate your parents. Maybe you put this on your website and say, you know, you can go to this, or maybe you put it on there and they sign off that they watched it and turn something into. You decide how you're going to use it, but it's a helpful piece of information, and that's what the NCAA has created it for. This is the handout I mentioned before for parents. Again, this is the back page of the SCAT-2. When an athlete's concussed for us, we do the SCAT-2. I make a copy for mom, but then I go over and I highlight the signs to watch for them. And I highlight what they have down here, other important points. And so if little Johnny starts throwing up when he gets home, or he takes a turn for the worse, they at least have something to go on. You know, we didn't just send you home with no guidance. And then I also go over the return to play, because, guys, if there's one thing in the last few years that I've had more frustration with than dealing with parents, we really haven't had it this year as much as we did last year, at least with a couple of kids. Cheerleaders were the biggest offender for us. Is the return to play. Parents understanding that you're going to see the doctor, and he's going to say, okay, you got a concussion, here's what you need to do. But once you're asymptomatic, I don't care how big that big cheerleading competition is on Saturday, you've got to go through the graduated return to play. That is that day of several days of progressive intensity to see if symptoms return. Because you know what? Sometimes they do. Day 2 is the one that usually gets it for us. That day that we have is an intense, you know, it's non-contact or anything like that, but it's about 15 minutes of intense exercise. If it comes back, that tells us, okay, go back to square one. SCAT-2 assessment. Again, this is where we start. We keep them in our bag. They didn't do a SCAT-2 on Colt McCoy until the next day, according to the reports. This is something that you ought to have in your bag. I usually take it out, and we go usually to the trainer. If I've got somebody else on the field that can, you know, my assistant, or maybe there's a team doc, I'll leave them there, and we'll go to a place that we can be me and him, that we can do a good assessment. If you can't do that, you do it as soon as you can. Okay? But this tells you the extent, because if you just ask them, you have a headache, and you go over the little, you know, kind of the basic, the way we used to assess it, you just aren't able to tease out some of the things that, oh, God, this kid has a huge balance problem. Or this kid, he can't do this part of the assessment. You know, it's always interesting to me to see this kid who has a concussion struggles with this little part of the assessment, but this next kid that comes in and does great on this part, but does terrible on this part. It's really kind of fascinating to see the difference. But what this does is it quantifies how concussed are they? You know, where are the issues? As I mentioned before, it includes a symptom score there. Each of that first page is kind of the symptom score part. It includes part of the SAC, part of the BIASC. It includes the Glasgow-Coma scale. It includes, you know, lots of pieces of other people's work that put it all in a 100-point scale. So it can be used to monitor improvement as well. Okay, they graded a 73 last night. They come in and see us again, and we do it, you know, and now they're at 83. Well, that's good. We hope to see them improve. A concussion that's not improving or that is worsening is certainly something to be more concerned about than one that is resolving as you would expect. Again, combines portions for orientation, that is knowing where you are, consciousness, concentration, immediate delayed memory, balance, and coordination, all into one assessment. It takes about 10 minutes, 15 minutes maybe to do. But again, I would encourage you when you do this, you do it in an area that is, you know, not, it's hard to do this on the sideline, you know, with the band and the lights and just all the distractions and everybody asking about it. You know, you got to get them off to the side so that they can really focus. When I do it in my office, I shut the door. You know, from the rest of the athletic training room, so that they can put the very best foot forward. I don't like anybody else to be in there when we do it. Mom and dad can step out, because when they do in front of somebody, they sort of feel like they're performing, and I'm not sure it's their best. Here's the symptom score. You can see 22 different symptoms. They rate it 0 to 6. We ask them to come in every day. Okay, Johnny was concussed on Monday. We're going to try to get him in to see one of our team docs who's kind of specialized in concussion within about a 48-hour period. This is what they like to do. They like to see them within that period. And then we want to see them every day to see if their symptoms are getting better or getting worse. New ones are popping up, this one's getting better, this one's getting worse. What we hope we see is they progressively get worse. A lot of times they go to class and they come back sick at the end of the day and they're worse than maybe they were at the beginning of the day because of the mental exertion and just what's required of you during the school day. Exertion doesn't have to be, hard physical labor or exercise. SCAT 2 assessment, this is what the last page looks like when you kind of tally it up. Again, you have a SCAT 2 in your package. It's a nice way to get a big picture of what you're doing. I wonder if we went back 10 years ago, and some of the kids that we asked those questions of, that we maybe suspected a concussion with, they kind of gave us the right answers and we moved on. How many of we've had this tool then? How many of them would we have identified? We use Impact as well. This is our 4th year with Impact. We started using it in 2008. We, at that time, paid for it ourselves. We were, to my knowledge, we were the first school. I know there were some hospitals that used it at that time. First school to pay for it and implement it with their athletes. Impact's not the end all, but it's a helpful tool in the toolbox. It helps identify some things that you really can't identify any other way. It's a computer-based nerve cognitive test, usually elite levels of score. Athletes are administered a pretest. That's the cumbersome part of this. That's the hard part of this for a school, is to do all the pre-testing. At the beginning of every season, we're kind of early in the spring season now. I've got the rosters from the coaches, and I go down and say, okay, who hasn't had a test in the last 2 years? A baseline test. And we pull those kids off. Of course, if you're new to our school, you're automatically going to have this, but, okay, soccer girls, which ones do we need to test? And we schedule a time for them to come in after school, and we do the testing. Takes about 30 minutes. Hardest part sometimes is getting them all in there at the same time, because I like to move them through kind of as a cohort. The first part is kind of demographic information, then there's some sort of symptom score stuff that they shouldn't have any symptoms, baseline, but you kind of have to, you got to get a baseline. And then you progress into the actual test. It tests memory, it tests reaction time, it tests how you get into distraction. And again, it just teases out some things that you really couldn't get another way. Post-injury tests are conducted after asymptomatic. People use this different ways, and we've changed some of the way we use it this year, and more clinic has encouraged us to use it differently the way they want us to use it. And I'm trying to go along with the concussion occur usually. You've already determined a concussion has occurred by the time we're using Impact. Most of the time with Impact, it's, okay, let's see how bad it's affecting these areas. It gives you data on a normative scale, and so you can see what percentile this kid's in. Even if you don't have a baseline, you can use Impact data and compare it to the normative stuff. When a kid's in the first percentile, you know they're not right. Okay, especially if they're a college prep kid going to college next year, and they've got 2 scores, one in the below the first percentile, one in the 7th percentile, and others in the single or low digits. That he's obviously not functioning. So Impact scores must be back to baseline. So really where Impact is most helpful is, okay, the kid thinks he's ready to go back. Now let's let him do Impact and see if what's on the computer matches up with what he's telling us and some of the other ways we monitor. What I have found is oftentimes Impact, the kid will say he's asymptomatic. He'll believe it. He's not lying to you. He thinks he's asymptomatic. And sometimes Impact data does not reflect that. It shows that some things are still resolved. Yes, it may have gotten better, but it's still out there. Again, impacttest.com is helpful. You might think, well, this got to be expensive. Guys, the $500, and you could probably test most of your folks that you would be any higher risk. Granted, if you're a bigger school, maybe more. But I guarantee you, if you're willing to spend $500, you could at least get a flavor of this and decide whether it's worth using at your school. You do have to have a computer lab. You do have to be committed to being willing to do the baseline testing. You do. I would recommend have a doc that knows what he's doing when he sees this data, and especially the first couple of years. There wasn't a lot of that around here in terms of when we have a report, we'd send it with them, especially if it were outside our network of physicians. But even then, the first couple of years, we were all learning. So recognizing this is new to your area, everybody might be learning. Notice, this is a post-test for an athlete. The stuff that's in red indicates scores that are below baseline, that are a problem. They are actually 2 standard deviations below the, what they scored. So originally, you see this athlete was 96th percentile, 42nd percentile, 28th percentile, 35th percentile. When he was tested a few days after his concussion, you can see that he kind of lit it up pretty good. 2 that were below the first percentile reported a assessment score of 34. Okay. You might say, wow, his reaction time is outstanding. Guess what? If you answer really quickly, but you answer really wrong, that kind of explains it. They were answering quickly, but not correctly. Notice Hap swung the other way the next time it took it. He answered more correctly, but he answered very slowly. So you almost have to wait for it to kind of come back in the middle. Once you see no red, then you're getting into the clear. With this athlete, the problem was his impulse control was still very high when compared with his baseline. And so while that didn't light up in red, he felt it was a problem. Graduate return to play. I've mentioned this lots of times. If you don't know anything else from what I told you today, don't put a kid back in that's been concussed or that's suspected. And if they have been concussed, use a graduated return to play. Make them do increasing levels of intensity. You'll see people interpret this a little different. Okay? Ours is based on Zurich, but what you call light exercise or what you call intense exercise, there's a little bit of interpretation there. If a kid, let's say on day 3, symptoms come back, we make them go back to day 1. Be asymptomatic for a 24-hour period and start day 1. I've seen other people, I think in the University of Georgia was doing it this way, where they just made them go, they made them stop at where this 24-hour period and start back up. We're working with the developing brain, they're working with a brain that's a little bit older. This is what we're doing. You decide what you think is best for your place. Read the guidelines and you go with it. But make sure you incorporate the graduated return to play. This is one of the frustrating things. Again, when the parent gets that note from the doctor, and usually this is a doctor that's outside our network, Johnny's cleared for return. How do you argue with a neurologist that says, yes, he's been concussed and he can go back? Well, he hasn't done what the guidelines say. Have you not read his papers? What I want to tell him. But that's usually where our arguments start. That's where I try to convince mom and dad. I say, look, this is what I recommend we do. If we're not going to do this, it's hard to argue with a neurologist. Try to convince them to this. Now, I might think I've developed enough of a relationship that will trust me that I'm doing what's right. Return to play forum. The high school league actually has a forum. Anybody using that? High school league return to play forum? Not me. They didn't. I just happened to be on the website one day and noticed that they had posted it. They based it on the North Carolina forum, which is a good forum. If you're not using a forum, or your docs aren't using a forum, I'd encourage you to go to the high school league, look at their return to play forum. If one of our kids were going to somebody outside our physician group, I would probably send them with that form, because you know what? I'm not going to get a form at all if I don't. I'm going to get something minimally accurate at best. But it breaks down some of the conditions under which they can return or whatnot. So if you're not using anything, or you want something else for your file, or maybe those times when they go outside your physician group and you don't get that form that you need, or you know mama's going to take off to this guy, go ahead and put that form in their hands, so at least you have some. Again, you notice at the bottom of it, they've got the gradual return to play, trying to make sure everybody understands that. One thing I've mentioned today a number of times, this isn't just an athletics problem. This is a school problem. This is athletics and academics more than any other injury that might occur in athletics. Number one, what have we done in our school to try to lay some groundwork here to make sure teachers understand this? This isn't an athletic problem, this is a health problem. Number one, I've gone and had a concussion presentation at the teachers meeting. When we started impact testing, I let them know, here's what we're using, here's our policy, here's what we're going to be doing. So don't be surprised when you get an email from me saying Johnny's been concussed and here's what we need to do. Sometimes those videos like I showed you there, the ESPN video and some of the other ones that kind of come across, sometimes I'll either find them or somebody will send them to me
I'll forward them to the teachers and let them watch, just so they understand what we're dealing with here, the stakes that we're dealing with in terms of potential severity of injury. Yeah, Tim?
What about hip hop?
We're under
Letting
FERPA.
a teacher know about a medical.
We're under FERPA. And we have our athletes sign a consent decree. We can share information as needed with school personnel. So I see this as no different than the school nurse letting them know the kid has asthma. I would worry more about not letting the kid know, and then mom going to WIASC and saying, my kid was concussed, and she made him take the test, and she won't let him make it up. We're just trying to stay one ahead of that. And again, their school record, this falls under FERPA, really, which is, their school record is their academic and their adult stuff that occurs with us. And
Would that change if they're 18?
I don't think so. They're still a student in our school. Sometimes I just take the philosophy of I'll get my hands slapped and do the right thing, and we'll figure it out. But again, email the teachers. That's part of what we're doing. I have a standard email that I copy and paste over. And I've changed the kid's name and whatnot, just to let them, I'm going to pull it up for you in just a second. But I include with that the CDC concussion fact for teachers. Because here's the thing. If you don't let the teacher know, well, Johnny's got his head down. What does that look like if you're a teacher in the classroom? That doesn't look like concussion to them. That looks like difficult student not what to do. So you got to let them know that this is part of what they have. If it doesn't resolve, we call for a sit meeting. A sit meeting is essentially intervening on behalf of the student. And most of the time, these are like behavioral problems in school or something else going on in their life. But this is, down the road, we'll be dealing with IEPs and 504s for this. That is those special needs kind of documentation that red tape. Yeah, I think it could. And I think if this is long-term, if they really have post-concussion syndrome, that's probably what you need. But for symptoms that didn't resolve in sort of a timely fashion and through the normal means, we've called a sit meeting. Example, we had a student, he was a senior, he was a college prep type student, AB student, and in the midterm, in 9 weeks, he had 2 C's and 2 F's. And the 2 F's were in math and English. He wasn't even going to graduate from high school if we didn't intervene, And so, we had to change around some schedule for him and make some other accommodations. And again, he's kind of the poster child for something that seemed so minor at first. He actually did it in National Guard summer boot camp. Came to us first day of football practice, walks in the office after practice and said, I think I might have a concussion. I got a headache. We sit there and tease it out. This was a kid that he was having symptoms 6 months later. He was one of the most complicated cases. And yet there was no big incident. There was never a loss of consciousness. There was never in a different era, this might not have even been connected as a concussion, his problem. And he's the one that you need to think about when you get the teachers involved. Because sometimes I get emails from teachers saying, "Are they still concussed? It's been like a week." I've actually got an email I keep on file for that one too. I may have it in this file. I took it out. But one that says, there's basically a little firmer tone in this event. That is, one of your athletes was concussed yesterday at practice. We're monitoring closely. It may take several days, sometimes weeks to resolve, et cetera, et cetera. I include that CDC handout so that they have here's some accommodations you can do for them. Here's what you should expect. And so, sometimes they'll, I think most of the time now they understand. They've had kids come through who are concussed and they understand, okay, this is another one of these. You just kind of have to keep them in the loop as to when this is running its course and when they're back. And one of the nice things now in working with our team docs at the clinic is they send home a sheet that says, here's, kind of specific to the classroom. We make a copy and send it with the kid into the classroom so that it's not just coming from me, it's coming from the concussion center as well. Recommended resources. NCAA, if you Google NCAA concussion and sport webpage, all kinds of resources there. That's where I pulled up video from. That's where I pulled our handout from. I haven't even looked at it in the last few months, but I bet there's some new stuff there that might be even more helpful than before. CDC is very helpful. The heads up, which is really under the CDC, but it's a different little part of their website. Again, lots of resources there. If you're looking for, you don't have to create all this stuff. You just have to kind of gather it and then decide, okay, we're going to use an NCAA education handout for this. We're going to use the CDC for this, and we're going to use the return to play form that the high school leagues use. Maybe our team docs want us to use this one. You kind of have to get, when you're making your plan and coming up with what are we going to do, these are really helpful places to go to get to not have to recreate. I put this slide in, I won't show it to you. Anybody know who this is? Come on, sir, not that. This is old school people. Yep, Steve Martin. Who is it here? Theodoric of York. You're the first person. I put this in a number of talks. Theodoric of York was a medieval barber. Okay, and if you watch this, it really is worth going to YouTube and finding Theodoric of York. Okay, I've actually shown this in my class before when we were talking about kind of archaic medical practices and how much medicine has changed over the years. Guys, concussion has changed a lot. Don't be Theodoric of York trying to bleed people for something that ain't the right thing. Okay, be progressive. Stay on top of this. I don't feel like I make up anything. I just read and figure out, okay, what can we do at our place? How do we make this work? What are other people doing? And then you come back and say, what's the standard? What standard are we going to be held to, both in the court of law? What are we going to do because it's right? How do we provide the best health care to our kids? So you have to come up with what works at your place. But you don't want to be 1997 American Academy of Neurology, sending a kid back after just thinking sitting him down for a period of time and not really digging into it and doing some of the other assessments is going to be after, or you wind up with what we started with. And that is a tragedy. Any questions? Yes, ma'am.
This came up in our school district a couple weeks ago. A girl, basketball player in high school, was basically knocked out and had head injuries, essentially, that he had ER. And the next morning, the school nurse was called out to see how she was doing. Nobody let her know anything about it. The child had been injured. So that just brought up some questions in our district. Coaches letting the nurses know. So that's a great resource for the nurses.
Well, I think what you have to worry about, if you guys are coaches in a school without athletic training, which if you're in the middle school, you kind of are. I mean, it's a rare place where the middle school would have an athletic trainer that's a standalone based at the school. I mean, we provide services to our kids. But I guess what I would say is, number one, we try to send out that email to teachers, but I CC the guidance counselors on it. I CC the school nurse on it. I CC the administrators on it. So, if they show up for a discipline problem in your office and you're the discipline principal, and these things, you're like, oh, yeah, this kid does. Or if you show up at the nurse saying, I got a headache, can I get some Tylenol?
Had like 2 weeks later and was headaches, and that would have been helpful had we known, and now onward.
Well, and I think you got to ask the question too. I think you got to, when a kid comes in and says they have a headache, you got to dig and say, why do they have a headache? Everybody gets headaches sometimes, but if your headache and you bumped your head last night, we got to put you in the concussions until we rule you out of that. And again, it's sometimes it's hard because it seems so minor, and it seems like we're always doing this. There's rarely a time there's not one of these going on in our program. There's not one of these things where a kid's coming in for a daily symptom score. I mean, there are times when there's 3 or 4, but I think it's something that if you're not seeing them, you got to ask yourself, why am I not seeing them? Because they're there. They are there, especially if you're in football season and soccer season, the times that these kids are sustained. We had 4 in middle school football this year. We haven't not had a lot of concussions in middle school football. We have not identified a lot of concussions in middle school football to this year. And part of it is too, and middle school kids are kind of like this. One goes up to the training room and then all of a sudden got shin splints. All 12 of them coming through there. So it made me kind of think was a little bit of that. But you know what? We assume, we start and say, okay, we think this, and then we work it up. And guess what? We got numbers that can say you do. It's not just me saying this. It's objective tests that show us these things. We haven't done impact testing with our middle school kids unless they were on a high school team. And we got our JV girls soccer team is pretty much middle school kids. There's a few ninth graders, but mostly middle school kids. Our JV softball team is probably half middle school kids. We are doing those kids. It's harder to do kids who are at a different school and get them lined up there to do the testing, but I guess we decided that we're going to do it because it's important enough to do it. Now the question for me next year is, do we include, knowing that we had 4 concussions in middle school football this year, do we need to figure out a way to do those middle school kids too? And again, it is time consuming to do this, but at the same time, what preventive measures do you do for this problem that are any more important than sitting down and doing that impact test? If nothing else, raising awareness, that they'll come back and tell you when there is something, even beyond what the test may tell you. So that's something that if you say, what are we looking at our place? You know, do I maybe look to add those middle school football guys, you know, to our list of, okay, we want to figure out how to test it. Maybe we go down to their computer lab and do it on their turf. We bring it up, you know, to our place, so it's not hard for us. But that is about, you know, probably 80 more kids. That, usually when we do that testing, we try to usually no more than 20. The computer lab probably has 25 or 30 computers in there. We like to put a seat in between them. We make sure they understand the serious, you know, this is a serious test and there would be no fooling around. We don't have a problem. I can be a mean, talking with a mean voice and people attention. We get it. But that would be kind of a frontier for us right now. How do we expand what we're doing and do it better and you know, make sure that when these events happen that we have the data we need to carefully as best we can. And again, you can use it without that baseline, but it sure is helpful. Other questions?
It's not a question, it is a comment to follow on what Ron was saying, because I think it is important that all professions that work with students be aware of what happens with that student athlete, and making sure that the school nurse knows is important. The school nurse will do an assessment, but sometimes a student may not say that they were actually hurt during the game because they want to go back.
Right, and that's where you got to put that onus. You got to put the onus on the kid. You know, when we talk about sports medicine team as a concept, we talk about not just the athletic trainer, the coach. We talk about the athlete, the parent, you know, being part of that. And this injury more than others, they have to be willing to do that. And if they don't, you know, I guess in the end, they're the ones that are going to pay the price.
A lot of times they take care of their own in the gym, you know, and they don't expand it. I think that happens in our county, I don't know if it's but they take care of everything through athletic. It would be nice to have school nurse involved in following.
So that's just something maybe, you know, how do you do this? Again, using your personnel and your resources, knowing your situation, having this information, how do you go back and say, okay, how do we do this better? How do we improve communication? How do we improve assessment? How do we improve maybe even access to providers off our campus? Because this isn't, you know, this needs to be something that, you know, if you talk to different people and they'll say, well, should the athletic trainer be referring the concussion or should they be treating it in-house? And it used to be, went back a couple of years ago, the way we did it was if it were something of a relatively minor concussion, we dealt with it in-house. And we followed it. We did the same things that they would be doing, but we didn't necessarily involve the physician. As of a couple of years ago, just given the climate for this and the potential for catastrophic injury and the sort of cover yourself, and you know, and plus in the resources we have, the fact that we have a concussion center that we're affiliated with that's 20 minutes away, 25 minutes away for our folks, why not? And so yes, that's part of our plan now. We send if they're concussed. Of course, with the high school league now, they've made it kind of easy on that because as of this year, you got to. You can't keep it in-house. Whether that's necessary or not, you can debate that, but that is the rule. So, yes, ma'am.
George, how do you answer the parent or the head football coach of the junior who starts at middle linebacker and he took 4 months to recover from his concussion? What kind of helmet are you going to put him in?
You know, I have an uncle who was an engineer. He's a retired engineer from SCG. And engineers always think, how do we build something? You know, I don't really think like that. I say make sure the helmet's fitted properly. Okay? So if you've had a bad experience with a helmet in the school, then you know I treat that just as a bad experience with a pair of shoes. I wouldn't mind either. But I guess what I'd say is make sure it fits properly. I guess it'd be nice to document that it's fit properly, and that it's got appropriate stickers and clearance from it. You know, if they think a different helmet, but the data really does not. The salesmen say that, but the science is not telling. I tell coaches all the time, guys, they come and say snake oil all the time about MRSA, about cramps. Rub this on, it makes the cramp go away. Really? Let me give you a lesson on physiology, because that ain't how cramp. It's kind of the same thing here. I think there's great potential. I think there's great potential in a better helmet, but that's not my job. That's not what I can do. And I just want to make sure whatever resources we have that we are, doing it as best we can, and that we are reading what's coming out on here. If there is a better helmet, but when they publish that in the Journal of Athletic Training, or they publish it in JAMA, or they publish it in something that is not a piece of sales literature, miles. But at the same time, when you say, have we changed physical development this year, all of a sudden we've seen more problems, anecdotally, you can't even go about it.
George, this goes a little bit further than just concussions and stuff, but just for the athletic injuries, period. Not everybody's as blessed as we are at Whitehall High School to have a wonderful nursing staff and that kind of thing, because they are a member of our sports medicine team. And you guys, I encourage you to go back to your schools and email or talk to your athletic trainers. And if you don't have an athletic trainer, your athletic directors, your coaches, and that kind of thing, and say, hey, look, I'm a part of your team. I'm on your side. Let us know when you have problems, because I get emails from Katrina all the time that says, hey, I got your track athlete today. I told them to go see you after school, and we can follow up with these kids if they come in, and if they don't, we know to kind of look out for them, that kind of thing. But I encourage you guys to, also be a part of the team there, because Katrina sits in on our SIT meetings when we have them, and very great part of our sports medicine team as well. So I encourage you guys to go back and talk to your athletic trainers and athletic directors or coaches if you don't have an athletic trainer.
I mean, for me at my place, she's really, other than my assistant, my only real colleague that's a healthcare provider, and again, our similar situation, ours very, very much of a team approach. Sometimes, again, the kid may not even recognize it. She'll alert us when there's a problem with one of the athletes that she's seen. A lot of times I may have seen them already and we know what's going on. Sometimes not. Okay? Sometimes they pop in there during second block, English or whatever, and Mercer's another good example of that. Sometimes she catches it, sometimes I catch it. It's going to go into her classroom, it's going to come into my athletics area. We don't want it in either. And so, a lot of times, good communication with the school nurse, again, is part of our plan, and something that we need them and they need us, and in the end, our athletes who are students are all safer and healthier because of a good relationship.
Thank you, George.
Thank you.
Everybody, we're going to take a 5-minute break while we switch computers, so you can just be back in 5 minutes. Rachel Sharp, she's with the University of South Carolina, football and cheerleading. She's an athletic trainer, and she's going to talk to us about concussions from the university perspective. Thank you.
Good morning. Thanks everybody for being here. Just taking the time out of your day to kind of learn a little bit more about concussions, because as George talked about, it's a huge topic, a hot topic right now in sports in general. Like George said, my name is Rachel Sharp. I primarily work with football at the University of South Carolina, but I do have responsibility covering the intern that's responsible for our cheerleading coverage. I'm going to start out this morning with a little cartoon. This pretty good football player, he says, "I'm slow, coach, put me back in, it's just a bump." Hopefully, this is not what's occurring anymore due to the education of concussions that has come out recently. But this is one thing that because all athletes are going to say this to us. They want to be back in the game, they want to get back out on the field, especially when you talk about our level. I worked 6 weeks in the NFL as well during preseason, especially during preseason in the NFL. Those guys are trying to make a team, they're trying to make money, they're trying to not lose their jobs. So concussions become less important to them at that point in time. That's why hopefully the education that we can provide to you and that you can get from other sources will help make sure that this doesn't happen, that those athletes don't go back in the game and they don't just say it was just a bump, but that we can use those signs and hopefully they'll report their symptoms with their own education so that we can prevent the negative effects that can possibly occur from concussions. Right here's a little graphic I put together. Yesterday on Google, I searched concussions in football, and the news section, and these were all in the last 24 hours, news headlines about concussions. So you can't read all of them, but you got movement grows to minimize hits for young football players, local doctor helps prevent concussions in student athletes, concussions hit teens worse than adults. Is football too dangerous for schools to continue to maintain teams? This is just from yesterday, the last 24 hours, headlines about concussions. Now, if you've read a lot of the news, you know it's a huge topic in the NFL right now. There's a number of players in the NFL that are actually suing the league due to the negative effects that they feel that they have from concussions. Boston University has a whole center that's dedicated to concussion and traumatic brain injury. They're actually looking at also subconcussive hits, so hits that don't even qualify as a concussion. How are they going to affect people down the line? Alright, so like I said, there's lots of concussions are a hot topic in the NFL especially, and sports drives everything or most things in society today, so if the NFL is dealing with it, then it's going to trickle down, thankfully, to the college level and the high school level, middle school level. So if they're having to focus on it in the NFL, it's going to make us have to focus on it, which is a great thing. Alright, so I'm going to talk a little bit about what concussions look like at the University of South Carolina. This is just last season, 2011-12. We had 16 concussions last season. That's 15% of our players. We failed about 105 during the year, during the season. 16 people had concussions throughout the season. Just in one football season. I'm talking from August to January. 16 concussions. That's 95 days of practice missed. 13 games altogether. And 4 of those guys were starters. Now, obviously for them, they didn't want to be out, but also think about their teammates in practice every day. So every player that's out, that's one more rep that you have to go through in practice. You know, that's one more throw that you have to make. And when you're trying to play a whole football season, sometimes during practice, the most rest you can get, you know, take your reps, but also get rest in between, is beneficial to you. And so not only does it negatively affect the players that it occurs, that it happens to, but also their teammates can be also negatively affected during the season. One of these particular concussions I remember, we'll talk about symptoms a little bit later. George did a great job going over a few. This particular guy went in for a tackle, a low tackle. He tackled wrong. He went back and watched the tape after it was all over and said it was awful, but he got kneed in the head. And he was on the opposite sideline, curled up in a ball in a fetal position. We got there, and the athletic trainer on the other team told us that his knee was hurt. Granted, athletic trainer, he probably wasn't going to talk to him a whole lot because he didn't know him, but from what happened, the athletic trainer thought his knee was hurt. We get him back over to the sideline. Our doctors ask him a few questions, you know, check him out a little bit. He has a concussion. I go back and talk to him about 5 minutes later, see how he's doing, ask him a few questions. I stand there and talk to him for a little bit. The first thing he asked me was, what happened? Did I get hit? Did I get knocked out? Then he said, did we score on the play? Or did they score? He's a safety. Did they score? No, they didn't score. He asked me about 3 other questions. I stood back there a little bit longer and he said, hey, Rach, did they score on that play? I said, no. I said, was I knocked out? No. He asked me the same 5 questions. It was a timeout, so I stood back there a little bit longer. 30 seconds later, he said, Rach, did they score on that play? That continued the rest of the football game. We had 1 loss at the time. I said, who did we lose to? He said, I have no idea. I didn't even know we lost. That was 2 weeks prior. He doesn't remember from the time he got hit. It was after halftime. So from halftime, so we got off of the plane in Columbia. So that's the whole rest of the half, the locker room at the end of the game, boarding the plane, the whole plane ride. He took a nap. When he woke up from that nap, he remembers everything from that plane. He remembers getting to the field, but he doesn't remember that first half. So obviously, something went on in his brain at that point in time. And he's probably never going to get that memory back, but thankfully all the rest of his symptoms resolved, and he's doing great at this point in time. But that's just a little bit of a picture, sometimes how scary concussions can appear, and so you have to go through all the steps to make sure that there's nothing worse going on at that point in time. All right, now, George went over the Zurich guidelines, and like he said, I'm going to reiterate a lot of those because those are the gold standard. That's what everybody dealing with concussions should go by. So this is actually the definition that Zurich came up with in their guidelines. It's a complex pathophysiological process affecting the brain, which is induced by traumatic biomechanical forces. There's 5 different things that can be included. It's either caused by a direct blow to the head, face, neck. Everybody assumes that can happen. But it can also be an impulsive force that's transmitted to the head. So if you take a tackle blow and you get whiplash, that can cause a concussion. It's not a direct hit to the head, but yet the force of the whiplash is enough for that brain to hit the side of your skull and cause some kind of damage to the brain. Typically results in the rapid onset of short-lived impairment of function that resolves spontaneously, which is important to check those symptoms as you go along to see, because it is going to resolve, but you have to watch and make sure it does resolve, because if it doesn't, that's when you got something more serious going on. Concussions are more of a functional disturbance rather than a structural injury, which is why George said CT scans, MRIs aren't going to necessarily show you a concussion, because the structure of the brain most of the time is fine, but it's the functional issues that you have to deal with. A graded set of clinical symptoms, like we talked about. The resolution typically follows a sequential course. However, there are some cases where the symptoms are going to be prolonged. Another reason why you have to continue to check those symptoms. Like we already said, most times there's no structural abnormality that can be found in neuroimaging studies. Just the sheer hits that our guys are going to take during the game is enough to damage the brain, as I gave you good numbers and statistics to show you right there. Here's a symptom list that George talked a little bit about. Headache is probably the number one thing that guys are going to notice. Hey, I have a headache. Obviously loss of consciousness, but studies have shown that there's a very small percentage of concussions that actually include LOC. So just because they haven't been knocked out or they have loss of consciousness doesn't mean that they don't have a concussion. Confusion or disorientation, amnesia, like I already told you about, that can be retrograde, so before the hit, or what happens after the hit, either way. Dizziness or balance problems, slurred or incoherent speech, nausea, vomiting, vacant stare, visual disturbances, sensitive to light, blurry, double vision, inability to focus, delayed verbal or motor responses, feeling like I'm in a fog or zoned out, ringing in the ears, irritability, emotional ability or change, constant emotional change, fatigue or feeling slowed down, excessive drowsiness, and sleep disturbances. All things to look for if athletes come to you. Some are easier to see than others. Some you totally have to rely on them to tell you, which is why it's so important that they're educated prior to about the effects if they don't report the symptoms. All right, this is what concussion management looks like in our particular setting. At a D1 collegiate setting, you have a few more resources that you might not have access to at the high school or middle school level. We also do impact testing with all of our guys, every single one of them. They have an annual baseline cognitive test. And we do it all of our at-risk athletes, so like our women's soccer players, men's soccer players do it as well. But our football team, at the beginning of the season, they have to do a number of things. Get their insurance forms re-signed, get it fitted for their mouthpieces, and this is just another thing on the checklist. We have a checklist, and they have to come in and we check them off. We have 3 different offices. They go in, they shut the door, we check their cell phones, any kind of electronics they have on them, those cell phones, because they think they're, tricky, and they'll give you one and they go one in the pocket. So we take all their cell phones so they have no distractions. It takes about 20 minutes to do their baseline test, and then they're done. They don't have to do it again until next year, next preseason. But that way, in case something happens during the season, we always have something to refer back to. We also have immediate access to sports medicine physicians, immediate access. We have physicians in our athletic training room Monday through Thursday from 1 to 4:30, every Monday through Thursday. This is Dr. Jason Stacy. He's our primary general medical physician for the football team. And so he's there. Even if he's not there, we can give him a call and he'll meet us at the stadium and give them their scat to evaluate them, do all that kind of stuff. And then they can also have daily doctor's visits if they need them. Dr. Stacy doesn't necessarily want to see him every day. If they come in the morning to see us and they're like, yeah, my head still really hurts, I got this going on, he doesn't necessarily need to see them because he knows they're still symptomatic. And as long as we see that their symptoms aren't getting worse, then that's good enough for him for that day. So these are 3 things that not all high schools have access to that we at a collegiate setting take advantage of to deal with our concussions. We are obviously governed by the NCAA, being a collegiate athletic environment, and so thankfully, as our governing organization, the NCAA has put in their own guidelines for this particular situation. They come out with a sports medicine handbook every year, and all of this stuff came out in this past season's sports medicine handbook. So in the sports medicine administration, they have a new section that talks about the concussion management plan. All member institutions have to have a concussion management plan on file. New bylaw that was passed April 2010. It was actually passed in November, I believe. Guideline 2I states, well, it's about a 4-page thing that talks about concussion or mild traumatic brain injury. It gives a list of the symptoms and then talks about the new policy. You have to have a concussion management plan, and in addition, student athletes must sign a statement in which they accept responsibility for reporting their injuries. So just like George was talking about, they do with their high schoolers, that kind of got off the NCAA guidelines, this is the exact guideline for what we have to do with our student athletes. This is the actual bylaw that was adopted. This particular management plan has to include 4 things. First, there's an annual process that ensures all student athletes are educated about concussion. There's a process by which the student athlete is pulled from competition and evaluated by a medical staff member if they're showing the symptoms of a concussion. Thirdly, the policy says that those diagnosed with a concussion cannot go back to athletic activity that same calendar day. And then 4th, the policy requires medical clearance determined by a physician or the physician designee before they can return. This is our concussion management plan at the University of South Carolina. Nothing novel, nothing brand new. We actually took it from West Virginia, I think, with permission, and just changed the stuff for us. So it gives your definition, gives your signs and symptoms, talks about your evaluation, what needs to happen if you think somebody has a concussion, when you need to refer them to the emergency department, what physician referral looks like. We've got return to activity plan that George went over that we'll talk about a little bit later. Our post-concussion testing, which would be our impact. And then what happens if somebody has multiple concussions, which we'll talk about at the end as well. So every single athletic trainer has a copy of this, every single coach has a copy of this. Every single athlete has to sign what we call acknowledgement of injury or illness form. That's for any injury that they have. But they sign it, which is part of the education that they receive about concussion signs and symptoms. So therefore, we cover everything required by the NCAA guidelines. These are also some best practices that the NCAA suggests, not necessarily mandated, but if you're smart, you're going to follow these as well. Obviously, you want to encourage that the new rules are enforced, so that flagrant head or neck contact. And then have on file the emergency action plan. What happens if somebody has a concussion? What happens if it gets worse? What's your plan look like? Have on file the appropriate health care plan so that every athlete gets equitable access. Healthcare providers should be empowered to have unchallengeable authority to determine management return to play. This is sometimes difficult in a high school setting. I worked at a high school last year, and I know a little bit about dealing with coaches. They think, some coaches think that they know all, they're the, know all be all, but thankfully at the college level, it's a little bit easier because they know exactly why you're there, they know why you were hired, they've worked with athletic trainers in the past, and so they put a little bit more faith in you to make the decisions that you need to. This kind of outlines what the concussion management plan should have in it. Again, outline the roles of all the healthcare staff. Make sure the coaches understand the concussion management plan. And then it talks about the baseline assessment. And the minimum in the baseline assessment should be whether you use the SAC, SCAT, SCAT2, and the balance system. neuropsych testing, impact, which we'll talk about a little bit later as well. And then the student athlete should receive serial monitoring, which we've mentioned. If the symptoms get worse, obviously something else is going on. Student athletes should be evaluated by the team physician as outlined. And then finally, everything should be documented from day one all the way to when they return to play. Like George said, we're going to look at this several times because this is the gold standard, this is the foundation, this is where everything that we do comes from. The original group was Vienna 2001. It was made up of the FIFA soccer organization, the National Hockey League, and then also hockey, and the International Olympic Committee. So they're the ones that originally said, hey, let's get together and talk about concussion in sport, Vienna 2001. They went back in Prague 2004 to update it, and then finally we observed in 2008, published in 2009. SCAT-2 came out of Zurich. They decided to get rid of the simple versus complex definition of a concussion. There's no such thing as a simple versus complex concussion. It's a concussion, period. I was going to show you this video, but we had technical issues with the last one, so we'll just skip this one. This is just a montage of hard hits in college football. I mean, it's got a rap video to it, gets you really excited. You know, people sacking the quarterback, jumping up, coaches coming out on the field, congratulating them, all this stuff. This is what college football looks like today. Unfortunately, those same hits that are celebrated and is the big deal why everybody goes to games are the same ones that can have extremely negative effects to the actual athletes. One thing we must remember is that no concussion is the same. There's no formula. If this player looked like this, it took him 10 days to return, that means the next player it's going to take him 10 days to return. No, that's not the case. If everybody has a symptom score to start with of 40, that means he's going to return like this. No, that's not the case either. Everybody must be treated as an individual. That's something coaches have to understand too. If one guy comes back in a week and a half, that means he expects all of his athletes to come back in a week and a half. That can't happen. All right, this is what we do. So a guy takes a hit in the game. What happens next? On the sideline, and George said it's not the best place for a SCAT-2, so this is what happens on the sideline immediately. There's a symptom survey. Dr. Stacy goes over, asks him a lot of questions. Look up at the scoreboard. What's the score? Is that blurry? Do the lights bother you? All those, if you have a headache, all those different symptoms that we talked about. Secondly, orientation questions. What day is it? What month is it? Sometimes they'll ask, what did you have for a pregame meal? What did you have for dinner last night? You don't know the answers to those questions, so those aren't always best to do those kind of questions. But sometimes you can throw them in there just to see how quick they're going to respond. They're like, a really easy question, like, when's your birthday? They're like, well, obviously something else is going on. But if they can respond very quickly, then, or even if they give you a smart aleck answer, that means that their brain is working. Even if it's not the exact answer that you're looking for, it's not that slow response that we're worried about. Romberg's test is a balance test. It's very easy to do on the sideline. They just stand with their feet together and close their eyes. And then you can have them similar to the best test, but not exactly the same thing. And so you can see how their balance is. Do they start swaying when they close their eyes? They'll give you a little bit of a picture into what's going on. And then finally, something that's not always mentioned when you talk about concussions, but should always be mentioned when you talk about brain injury, is pupils equal and reactive to light. So if you have a pen light, pull your pen light out, shine it in both of their eyes, it should constrict like this picture up top on the left when the light shines in the eyes. If it dilates or if it doesn't constrict like the picture on the bottom on the right, you've got a more serious brain injury going on. And you need to go ahead and get them off the sideline and get them to where they need to be. So real quick on the sideline, if you've got, the lights are bothering me, that's their main complaint. Sometimes we'll give somebody sunglasses and let them stay on the sideline. If the noise is really bothering them, if they have a really bad headache, if everything, just feels awful, then they're going to go in the locker room. Somebody's going to monitor and make sure it doesn't get worse. After the game is over, when we have the time, or after practice is over, or in the middle of practice we can take them aside, they're going to do the SCAT-2 that George was talking about. tool designed for use in medical and healthcare professionals, like George says. It can be used from 10 years and older. I'm just you have a copy of it, thankfully, that George gave you, but we're just gonna kind of break it down a little bit, if anybody has any questions as we go through. So they have their symptoms, which is a Likert scale. They're just kind of circled, worse is 6, or severe is 6, 0 to 6. They can just fill out their symptom score. The second thing it has on it is a physical sign. So was there loss of consciousness? If yes, how long was it? How was their balance? There's your sign score. Glasgow Coma scale. Hopefully, in most cases, it's going to be fine. Do their eyes open spontaneously? When you say open your eyes, can they open their eyes? When you say speak, can they speak? And is it oriented, or are they confused? And then, if you say flex your arm, can they do that? Or is it they can only do it to pain? Or if you say move your toes, can they do that? Sideline assessment, or obviously if you're off the sideline, you're just asking them those orientation questions again. Where are we? If you're in the athletic training room, you say, what day is it? What month is it? What team did we play last week? Then you have your SAC, your standardized assessment of concussion. So you're doing your orientation questions. This time they're a little bit different. Like these are your month, date, year questions. Then you're talking about immediate memory. So give them a list of 5 words. They're going to repeat them immediately back to you 3 times, the same 5 words. Give them a score. Then they're going to give them the 3-digit. And the thing about the SCAT too is they're so easy because in the blue, if you notice, it gives you exactly what to say. So if you've never done a SCAT 2 before, then you can just read right off the thing and you're going to get the right stuff. And then as you continue to do it, you'll get used to it. You won't even need to look at this probably except to put down how many they got right or wrong. So have them repeat the digits backwards to you. And then the last one I have is months in reverse order. Did they get it right? Did they get it wrong? This is your balance examination or your best test. So the first thing you're going to have them do is stand with their feet together, hands on their hips, close their eyes. Hold it for 20 seconds. Then do the same thing with their foot raised, and then have them in a tandem stance, which is back toe to front. If they can do all that okay, put them on a foam pad and have them repeat all 3 of those. And what you're looking for is, did their hands lift off their hips, open eyes, stumble, if they move their hip up too much, lifting your forefoot or heel, or if they fall out of the test position for more than 5 seconds. Coordination, simply finger to nose test on both sides. Cognitive assessment, then you go with the laboring call. So tell me those first 5 words that I told you at the beginning of this. Put your score there, like George already showed us. And then this can be used, like we said, to compare. If you give it to them again, what do they look like from the first time you gave it to them? Great tool to use. Also comes in a pocket version to do on the sideline. Just throw this in your pocket. If you forget, pull it out, or if you forget what symptoms you're looking at, or you just want to make sure, just pull it out of your pocket or your kid. There you go. All right. So we diagnosed that he has a concussion. Now what? This is what we do at the University of South Carolina. Brain Armor is actually soft gel pills that have omega-3 fatty acids in them. It's a big long word that is abbreviated, DHA. There's 1050 milligrams of DHA in a single serving of Brain Armor, which is 3 soft gels. And omega-3 fatty acids have been shown to have beneficial effects on cognition. So when they get the concussion, we're going to give them Brain Armor, and they're going to continue to take a serving of Brain Armor every day. They're also going to rest. Physical rest. They're not going to do anything related to their sport activity or anything else. They're not going to go play basketball in the strong or in the gym either. They're going to do absolutely nothing. This is the hardest part of the whole thing, is getting to do this stuff. No cell phones unless you absolutely have to, so no texting all the time. No computers. no TV, and the last one is the hardest that we have to deal with, because they go home to practice and the first thing they do is sit down and play the game. When we had a guy almost get, he was so disoriented after practice one day, and we said, don't do anything. He went home and played 4 hours of Xbox. Obviously, the symptoms aren't going to be resolved the next day. Whether they were without Xbox, we're not going to ever know, because he did play the Xbox, which is going to cause all of that stuff that was affected by the concussion and most likely make it worse. So we can't follow them around everywhere. All we can do is tell them, don't do these things, and hope that they listen to us. All right, now, we might do this a little bit differently than other places. I'm not exactly sure how everybody does it, but we don't have somebody do their post-injury impact test until they're totally asymptomatic. Completely asymptomatic, then they're going to go do their post-injury test, number 1. These are actually from the Missouri guidelines, talks about the benefit of neuropsych and neurocognitive testing. It's been shown to be of clinical value, contribute significant information to the evaluation. It's also been shown that cognitive recovery may occasionally be slower or more quickly resolved in symptom resolution, so therefore it's good to check that as well. Impact is not the only test you can do. Axon Sports has the CCAT, the CRI by Headminder, the ANM by the National Rehab Hospital in Washington, and then we use the impact test. So there are other options besides the impact test. I think one of these might even be the CCAT, that you can just go online and take it yourself. There's a fee, but if your school, say there's a parent and they don't provide impact testing, you can go online and have your child take it themselves. All right, this is what impact looks like. It starts with a history, your demographics, and then asks a few questions: what year of education, what type of student are you in school. And then it talks about, have you ever had a concussion before? What's your history of concussions? And then it's going to go through 6 different things that test a variety of, you've got reaction time, speed, memory. It takes about, like George said, 30 minutes to do. The first test is word memory. So they're going to give you a series of words. There's 12 of them. So you look at the words, they'll give them to you twice, and then they ask if that word is displayed. You just answer the question. Next is the same thing with designs. This one gets a little harder, obviously, because it can be flipped upside down. That same design, just in a different orientation, but you answer the same question. Was this one of the designs? Next one is memory and speed test. This picture is shown, and before everything, there's a slide that gives you directions. So, and you can read that for as long as they need to. 3 of these things will actually be yellow, and so in a minute they're going to be asked to tell which one of those were yellow. This is reaction time, so if the red dot is shown, they're supposed to press the Q. If there's a blue dot shown, they press the P. And then they'll do a series of those, and they respond as fast as they can. And this is when they click which ones were yellow again. And each of these are done, the word memory is done only one time, the designs are done only one time. I think this is, you go through this maybe 4 times, 3 or 4 times, I think. Next is symbol matching. So they're given this line of symbols and line of numbers, and when the one that's shown at the bottom, they have to match at the top as quickly as they can. But they also know that in a minute, the symbols are going to be taken away, and they still have to match it to the number. So they have to remember that, as well as use speed to see how fast they can get the symbols matched to the numbers. So the symbols disappear, you still have to say what number was the symbol. Color match is next. They do a little colorblind test just to make sure that nobody's colorblind, so therefore it won't get thrown off. So they just ask you to click the red button, green button, blue button. Then they're going to show you the color words and then put it in a color. You click it when the word matches the actual color as fast as you can. So obviously they wouldn't click that one because that's in green, not red. 3 letters, and it's gonna stay on screen maybe 5 seconds. Then you have to count backwards from 25 as fast as you can. So clicking the button is 25 all the way to 1. And then you gotta tell them what the 3 letters were. Alright, that's actually the last test. So you do that, I think, 5 times, and then that's it. So, as you can see, there's a lot of different things that they're testing. You know, the reaction time, memory, speed, and then you're gonna get your report. Alright, now if you notice, this one was really bad. And so up at the top, if this was a baseline test, there's 2 plus signs, which means invalid. So if somebody does a baseline and it comes back with those 2 plus signs, they need to do it again, because for some reason they weren't paying attention, or they just didn't care about it, and so their scores are really low. And so you need to check and see, okay, what's going on here? Is there something that we need to look at, or they just didn't care, so they got to do it again? But it gives you a composite score with your norms, graphs, and then as they take their post-injury test, it's going to show the graphs beside the baseline. Symptom score is hopefully 0 for us all the time, because we don't have to retake the impact until they're completely asymptomatic. Alright, so after they take their impact test, then we're going to start talking about return to play. So this is the main thing that hopefully like George said, you'll take with you from today. So to begin the return to play protocol, the athlete must be asymptomatic for at least 24 hours at rest. So they've done absolutely nothing and they have no symptoms for a full day. And then they have to have impact scores close to baseline. It's hard for you to say they have to have them exactly back to baseline because there's a lot of different factors that can go into that. But that's kind of a case-by-case decision that Dr. Stacy makes, whether he thinks the percentage that they're within is good enough. All right, so they have these 2 things, so now what? Day 1. Day 1 is light aerobic exercise, less than 70% heart rate. For us, we bike, stationary bike, for 20 minutes. The objective in this particular stage is to increase the heart rate. If they're symptomatic, which is where we're a little different than what George was talking about. If they're symptomatic, they're going to do the exact same thing the next day. If they're asymptomatic, they progress to step 2 the following day. So we only go back to the day. We just have them repeat the activity of the day. So on day 2, they're going to run, do sport-specific drills, and do weight training. Now, if on this day they're asymptomatic, they're not going to go back and bike the next day, or they're going to go back and do this again. They're just going to repeat the same day. Objective here is to add movement. So while they're doing that exercise, they've got to concentrate on this particular sport-specific drill. TJ has to concentrate on when that bag's coming at him. You know, with weight training, you're obviously doing more movement, lifting the weights, as well as increasing your heart rate by all these activities. So like I said, if they're symptomatic, they're going to repeat that same activity the next day. But if they're asymptomatic, they're going to go ahead and go to step 3. Step 3 for us is non-contact drills. So that could be, you know, DBs, backpedaling, receivers running routes, catching balls, doing bag drills. Down here in the left corner, that's actually what we put our guys in until they're cleared, a yellow jersey. So therefore, they don't have pads on, number 1. Number 2, they're in yellow jerseys, and people know don't touch them. They can't get hit. So therefore, they can go in and do some stuff like that might potentially be a contact drill, but people know not to touch them. So they can go run routes with DBs in the backfield, or DBs, you know, defending them, and the DBs know not to touch them, let them catch the ball and run down the field. Here, we exercise with coordination and cognitive load. So they have to start thinking about, how do I run this route? Or which way do I backpedal and brake? So you're adding, every day, you're adding a little bit more to the story. Same thing as before. If they're symptomatic, they're going to do these non-contact drills again the next day. If asymptomatic, they're going to go to step 4 the following day. But every single one of these are a full day. It's not like they're going to bike, and if they feel okay, then they're going to go run in an hour. And then they're gonna go do non-contact drills, or partial contact drills, non-contact drills an hour. It's a full day, and they get really frustrated about that. Because they're like, man, I just rode a bike, all I did was ride a bike for 20 minutes, I felt great, what can I do now? Well, nothing until tomorrow. Next, you got partial contact drills. So I'm not gonna throw you into a team period, or, inside, but you can do some one-on-ones, which is a little bit of contact between the receiver and the DB. You can do right here, this is our D-line. And you can do a little bit of, they're working on shaking defenders off, so he's not gonna be tackled to the ground. So they add a little bit of partial contact. This is what we add this step. Most people will go from no contact to kind of more contact. We do partial contact before we're gonna put them into full contact, just to make sure that they're gonna be okay, restoring their confidence, and their coaches can see how functionally how they look. Same story as before, but here we have, if they're asymptomatic, they can return to full, which whether that's gameplay or full practice. So you got full contact. So you can go do those team periods, you can go and practice and do that, or you can go ahead and play, depending on what the situation is. That's what our return to play protocol at the University of South Carolina looks like. And it's our coaches know that they have to take that process. They're not technically cleared until they get 5 full days of graduated return to play, which gets really tight in the middle of a season because if you think about it, if they have a concussion in a game, their symptoms have to resolve as in Monday for them to be able to play on Saturday. That doesn't happen very often. And so that's where we have to explain to coaches, hey, they have to be totally asymptomatic before they can even start this return to play protocol. And so I can't promise you he's going to be back for Saturday. And that's when they have to understand what's in the best interest of their athletes. All right, now we're going to talk a little bit about disqualification. Disqualification from sports for concussions is considered, there's no hard and fast rules to this. It's not like you can say, he's had 8 concussions in his lifetime, he's done with sports. But you definitely need to talk about it and look at him and talk about how long did it take the last time you had a concussion, how long did it take those symptoms to resolve. But that doesn't automatically mean that he's out, not from our perspective anyway. But like I said, if he has a history of multiple concussions, it needs to be talked about. If he sustains multiple concussions in one season, it needs to be looked at. So if this is a second concussion, this one needs to be, really looked at. How long are those symptoms going to take to resolve? And especially after the second one, the third, the fourth, the fifth. Hopefully nobody has a concussion 5 times in a season, but that's when you're really, really, really starting to look on that third one, second, third one. Last one, if the symptoms last for weeks or even months. This is a huge one. There's no reason that if it's just a normal concussion that those symptoms are lasting for a month, 4 weeks at a time. So that's when you need to sit down with the athlete, with their parents, with the doctors, with the athletic trainers, with the coaches, and talk about what the rest of your playing career looks like. But like I've said before, each decision is made on an individual basis, considering each individual's concussion history and response. No hard and fast guidelines, no exact rules to this. Here's another cartoon. We've got your concussion be gone machine that is sucking out of this guy's head that says, yo, Dewey, got another one over here when you're done. If only it was this easy. If only we could just put them in a machine or do something and know that they were going to be perfectly fine for the rest of their life and for after that particular instance, but we can't. Which is why everything we're doing today and everything that you do at your sites is so important. You educate them, you pull them out, when in doubt, sit them out, because there are consequences and there are things that can occur if it's not handled in the correct manner. Now, we hear a lot about concussions and their negative effects, but I want to show you a video about somebody who did the right thing, and there was a good outcome to their, not the best outcome, but, much better than could have been had he not done what he did. So this was the video that was playing earlier.
as soon as I did, the fullback had me as blocking assignment. And as soon as he hits me, I land flat on my back, and then the next thing to hit was my head snapped back.
Looking back, looked like basically nothing, but as he continued to play, he started getting weaker and kind of staggering when he got up.
So I go to the sideline and take a knee, and the next thing I remember, my speech was slurred, and I kept trying to call out to somebody, but I could barely talk.
There was no external bleeding. He was unable to respond to my verbal commands. His pupils were unresponsive to light. As I progressed more into our evaluation, I noticed that it was a more serious situation, a more life-threatening situation.
And the next thing I know, I'm waking up in the ICU on Sunday. What the doctor said happened was, as soon as my head made contact with the ground, it popped the main blood vessel in my head, and so my head started hemorrhaging. They said there was so much bleeding that they weren't sure if I was going to make it to the hospital or not, but thankfully Caleb was there. When you think about it, some schools don't have the programs where they have a trainer come out. Without the program and without Caleb being here, then I wouldn't be here.
Schooling has definitely prepared us athletic trainers for situations like, for instance, what happened on August 5th. We were taught what to do, when to do, how to do it. Then also, too, critical thinking comes into play as well. Your reasoning, why you're doing certain things. And then when you come out into the field and practice that textbook information, you get a chance to use your reasoning behind what you're doing and why you're doing it.
We're proud of the program that we've put together here at South Carolina. Our mission is to give students, undergrad and graduate, the most experience we possibly can in different clinical situations and different environments. We just feel that getting them, the maximum amount of experience they can get is beneficial. We're excited about that.
We have a few lecture classes, but mainly it's things like this. So you're really working every day when you come in here, doing your hands-on special tests, everything that you need to learn.
Here at USC, we have so many opportunities to do different things. We get an experience with a Division I collegiate setting. We get an experience out of the high school. We have the clinic setting, working with our orthopedic surgeons and our doctors, and even see general medical doctors in passing as well and work a little bit with them. USC definitely gives us all of those options for us to make a decision and kind of narrow down what we want to do in the future after we leave here.
Here, go like this. There you go.
Had we not had that here at North Carolina, and the Newberry County School District had not continued this program, for us, it was the difference between life and death, my son.
As far as the USC program, I think a lot more schools need to have it, and a lot more high schools need to have a trainer. That allowed me to be able to stand here and talk to you right now.
The video was actually made for the SEC weekly academic spotlight they do during the SEC Championship week, so that's what kind of highlighted the program. But it does point, and Caleb's not the only one who's ever made the right decision on the sideline. But he's a story that was told that shows the importance of having somebody there who can recognize those signs and symptoms. As soon as he started deteriorating, Caleb, the emergency action plan was ready to go. If I remember correctly, they had to bring the helicopter in and they got him to the hospital. And they got the surgery when it needed, and he's still alive. He's never going to play football again, but he's alive, which is the main part, and he's functioning very well at a high level. So that's why this topic is so important, and why hopefully you learn from today these different things that you can do on your sideline. Just references that. Does anybody have any questions? This is actually our staff at the University of South Carolina football staff and the students that we have this year. And if anybody wants a copy of this presentation or anything that I talked about, then you can feel free to email me and I'll be happy to send it to you electronically. Anybody have any questions? Yes, ma'am. To be honest, I cannot tell you why. It was in place before I got here, and I never actually asked question why we chose the impact test instead of some of these other tests. Sorry about that. Yes, ma'am.
Why do you test them every year on their baseline?
Why do we test them every year?
Yeah, because I know the recommendation for college and professionals is once during their career.
Like, again, I don't know the exact answer to that. That was another thing. I've only been here since August, so I don't know why a lot of those management decisions were made as far. I know, obviously, for new guys coming in, that's very important because we don't have their baseline yet. So, yes, sir.
Open question. Those of us that are using impact tests, how many times do you give a kid a chance to pass the baseline? How many of you had more than one kid? I've had 2 kids fail the baseline 3 times.
Here's what I say to that, Gary. In every group we test, like yesterday or Tuesday, we tested a bunch of kids baseline. I guarantee you, when I go through there and check, that's something I had to learn through sort of trial and error, to go through there and check, because there's going to be 1 or 2 in every bunch. I've never had a kid that, after we went back through and kind of went over the directions with them, made sure they understood. Most of the time, it's not their sandbagging, that they don't understand one part. And I guess we've not had a kid who, after we kind of went back there and talked about things, that came up double checks again. But that is something you need to check and make sure they understand the direction.
Gary, sometimes we have to take the kids and test them one-on-one. They can't do it in the big setting where you have them in the big computer lab and you have to sit there and test them one-on-one and be in there and them done that.
Yeah.
Are they
One-on-one
ADD?
individual. After they fail the first time.
They're not understanding some questions.
Yeah, they're not understanding something.
They're not understanding something.
Well, needless to say, after these 2 individuals failed it 3 times, they were.
I called Impact and asked them to take.
I did. No response. Not special ed, no other problems, failed it 3 times.
So no other special education needs on this kid?
No.
We come to South Carolina. We have major issues with that because of learning disabilities and other handicaps.
Anybody, any other questions? Yes, sir. I think there's no research that has exactly shown that mouthpieces mean you're not going to get a concussion. So ours are more so because they're going to wear mouthpieces anyway for their, to protect their teeth and everything, and some of them would rather have them fit exactly to their mouths than other. We don't custom all of our guys, just a handful, the ones that ask customers. So. Any other questions? All right, great. Well, thank you guys for listening.
Good afternoon, everybody. We're going to go ahead and get started for our last session. This is Dr. David Scott. He comes from Lexington, and he's at Moore Orthopedic Clinic, or the Moore Concussion Center, and he's going to give us the medical perspective on concussions. Thank you.
Thank you so much. Good afternoon. My name is Dr. David Scott. I'm one of the primary care sports medicine physicians at the Moore Clinic in Lexington. And I'm going to talk a little bit about the medical perspective on concussion. I think a lot of the pre-office management issues have been discussed already by some of the athletic trainers. And so I'm going to talk primarily about why we care about concussions, what we fear with concussions, and how I deal with concussions in an office setting. So this is just an outline of what we're going to talk about. First, we're going to talk a little bit about traumatic brain injuries in general. I'm a physical medicine and rehabilitation physician by trade, so a large portion of what I did in my training is brain injury management. Now, a lot of that wasn't concussions, a lot of that was more severe brain injuries, but brain injuries are a topic that are really kind of close to my heart. So we're going to talk a little bit about brain injuries in general and find out where concussion kind of fits into the spectrum of brain injury. Then we're going to talk about the sports-related dynamics in concussion, and what that basically means is, when these folks come into the office, you have to consider the injury, you have to consider the influence of the school district and the coaches, of the parents, of the players. There's a lot of dynamics that kind of feed into the decision making
with regard to managing these injuries. We're going to talk about the adverse outcomes in sports concussion. And I think that's really important because we all know that concussions are kind of at the forefront of sports medicine right now, but what specifically is it that we're really concerned about? You know, why do we care so much? So we'll talk a little bit about that. We'll talk about what I do in the office when these athletes come to see us, and then we'll have a quick summary. So, traumatic brain injury 101. What is a concussion? In the Clinical Journal of Sports Medicine, it's defined as a complex pathophysiologic process affecting the brain that is induced by traumatic violent counter forces. So you take a shot to the head, and then you have symptoms, and the brain doesn't behave like it should. That's basically what a concussion is. That's a broad definition, but that's more or less what we're talking about. So where does that fit in the spectrum of brain injury? Well, brain injuries, you have your vascular brain injuries, where you have a vessel in the head that may bleed and cause damage. You have a ischemic insult, which means a blood vessel in the brain may become occluded, may not give blood flow or oxygen to the brain. You have dural violation type injuries, which in sports are hopefully unusual and atypical, stab wounds, gunshots, things of that nature. And then you have brain injuries that are secondary to biomechanical forces. Contusions, like brain bruises, coup and contra coup injuries, which is a description of an injury where something hits another object, the brain moves in the head, it hits the front of the skull, and then recoils and hits the back of the skull. And shear and rotational injuries, or diffuse axonal injury, BAI, which is pretty uncommon in sports. That's typically from very high energy injuries, like motor vehicle accidents and things of that nature. So concussions really kind of fit into this subgroup. It's a contusion. Although it's not completely accurate, I typically tell the families and the athletes, it's a bruise, it's a brain bruise. And some people kind of argue with that. When you get more detailed, you tend to confuse folks. I think that's the easiest way to think about it. It's a bruise, it's a contusion. So although calling a concussion a mild traumatic brain injury isn't technically correct anymore, the lingo seems to change every few years, it is a mild brain injury. On the spectrum of brain injury, it's a mild brain injury. The signs of a concussion, loss of consciousness, although that is not a requirement for a diagnosis. So those who argue with you and say, well, he didn't lose consciousness, he didn't pass out, he remembers everything, so he is not concussed. That's inaccurate. You don't have to lose consciousness to have a concussion. Amnesia, difficulty remembering what may have happened, cognitive impairment, I can't think straight in class, I can't really do this word jumble, I can't do the normal things in my daily life that are no problem. I struggle with my thought process. And behavioral changes. A relatively happy young man is now kind of depressed, or someone who's generally, very hyper and energetic, now it's kind of lethargic. And symptoms. There's a whole laundry list of symptoms for concussion. Some of the most common are headache, drowsiness, emotional instability, lights bother them, sounds bother them, loud noises. So if you injure your brain, it's important to take it seriously. It's a brain injury. So in the realm of sports medicine, we deal with shoulder injuries and ankle injuries and back injuries, knee injuries, but this is different. This is a brain injury. So your brain controls everything. Your brain controls how you do in sports. It controls how you do in business, or whatever your profession is. It controls your intimate life. It controls your life with your family. It controls how successful you'll be. So when I speak to my players, to the athletes that come in and to their families, it's really important that we not treat it like another kind of an injury. We treat it like an elbow or a shoulder, or he can play with this. We treat it differently. It's more important. And you would think that's obvious, but not always. So you really try to impress that upon the people that come in to see you. So let's talk about the dynamics that play into the decision-making when we're managing these injuries, sports-based concussions. You have player dynamics, the things that the player brings to the table when he or she comes into the office, how they're behaving, what their motivations are. You have parental dynamics, and you have coaching or school dynamics. So everyone is paying attention to concussions now, the athletes especially. They know that the medical staff, the trainers, the doctors are really on the lookout for these things. And they also know that if they are felt to have a concussion, they may not be able to play sports. And they don't like that, obviously. So, whereas getting your bell rung was once regarded as, just something that comes along with soccer or football or contact sport, now it's looked at a little differently. Players in all sports understand that, reporting concussive symptoms could take them off the field. They see it on ESPN and Sports Illustrated, and they see what happens to their teammates, so they're aware of this. So when it comes to player dynamics, under-reporting or concealing of symptoms is a concern. It's something that the trainers have to kind of be aware of and weed out, and it's something that the physicians have to be aware of and weed out. So there's research that kind of backs up that this is something that we have to pay attention to. Underreported concussion in high school football players. This is just one example from 2004. There are a lot of different articles in the literature now that kind of pour out the fact that athletes conceal these symptoms. This was a study of 229 football players. 42% of them did not report episodes that they had concussive symptoms. And when asked, some thought it wasn't serious, some didn't want to leave the game, some didn't know it was a concussion, and a lot of them didn't want to let their team down. So there's multiple reasons why folks that are having concussive symptoms or athletes with concussive symptoms conceal those things. And this extends up to the NFL. NFL underreporting of concussive symptoms. The Associated Press conducted interviews in November 2009. They interviewed about 160 players, and they found that about half admitted to having at least one concussion during their career. 30 of those noted that they had hidden those symptoms and the effects of their concussion. And a lot of players admitted to playing despite feeling dazed or wounded. So this kind of prompted the commissioner, Roger Goodell, to propose a plan that would require players to notify medical staff if their teammates were having concussions or concussive symptoms. This was ultimately opposed by the NFL Players Association, and one player, Mike Sellers in the Red Sox, was quoted in the press as saying, "We ain't no snitches over here." So that kind of speaks to the culture in football that we're trying to break. It's not necessarily informing on your teammate. You're trying to protect him. You're trying to help him. But when you share with the medical staff that a teammate may have a concussion, lots of times, that's viewed as kind of selling that teammate out, getting that teammate in trouble, or doing something that may lead to him not playing. So that's a culture that we consistently come up against that we're trying to break. So barriers to reporting. The player doesn't understand. The player doesn't understand that he has a concussion or she has a concussion. They just don't know what that is, and they don't understand. Through no fault of their own, they just keep those things to themselves. The player does not want to disclose the problem for fear of being removed from play, which is probably the most likely reason. Considered weak. I can play through anything. I can shrug this off. I can get in the game. Or fear of team disapproval. He looks fine. He walks and talks fine. He should be able to play. I don't know why he's not playing. He's weak. I'm mad at him. We need him for this game, this playoff game, and he's not playing. They don't want to let their teammates down. The coach doesn't understand or is biased, or the family doesn't understand or is biased. Those are unlikely. The coaches typically are our friends, and they understand more than ever now about concussions. Families too, for the most part. But sometimes you have to just consider those things. The coach wants to win. And if a star player is sitting in your office, perhaps the coach isn't being forthcoming about everything that's going on with him, or perhaps the family isn't. Perhaps the player doesn't want to let down the coach, or let down his parents or his family, or her family. Parental dynamics. This is big. So these are the parents that I like. When the players with these parents come in, these are great. If all the parents were like this, then the job really wouldn't be very difficult with regard to the family or the parental dynamics. These folks, you can walk them back. They want to do every possible thing to protect their son or daughter. You can walk them back a little bit. It's a bruise. Give it some time, it will heal, they'll be okay. We're okay. So these folks you can walk back. These folks are more difficult. You know, there isn't a good blood test, and there isn't a good x-ray, and he's walking and he's talking and he looks fine, and he's going to play. And I want him to play. And I played football, and I had this too, and I played, and he's going to play. So these folks are sometimes tough. So you have to kind of understand in the exam room, you know, you're dealing with a parent that's really very interested in their child's well-being, or a parent that is very interested in their child's well-being, but also really wants them to play. So they have pride in their child. Their own social status is a factor. You know, soccer games, the football games. Sometimes the families of the starters, well, they sit in a group, and the second stringer families, well, they sit in a group, and you know, it's a Friday night ritual, it's a Saturday ritual. We go out to the game, and you know, the parents socialize, and it's sometimes more than just the athletic event. So there are other issues with the parents than just their son or daughter playing. There's a lot of social structure sometimes tied into these things, especially with football. So sometimes, you know, they don't want their son or daughter to be on the sideline, letting their child down. Sometimes the parents come in as the savior. You know, mom, whatever you do, don't let him take me out. Save me, protect me. And the parents walk in there like, we're going to let this doctor know that he's playing. And little Johnny wants to play, he's playing. And I'm going to tell the doctor he's going to play, and that's it. So sometimes they've taken on this responsibility to make sure that their son or daughter is able to participate. And so they're bent on making sure that I understand that. Future athletic aspirations. Not all of these kids that I see in the office are going to go on to play in college, but some of them will. And sometimes it means not playing in a game where scouts are going to see them, not playing their playoff game or the last game of the season or what have you. And if they miss a game where they're going to be seen by a college coach or college scout, well, that's a big deal. So you have to respect that. You have to understand it. It shouldn't really sway your decision making when you're dealing with a legitimate injury, but you have to understand those things. So coaching in school dynamics. So coaches, by far and away, in my experience, are really supportive and really helpful, and they just want what's best. You know, they want their star players to play, but they're pretty committed to making sure everyone is safe as well. Sometimes the coaches give a call over to the office and say, just wanted to let you know, in case you didn't know, that state championship's on Friday, and you saw John this morning, you said he had a concussion, and making sure you're sure about that. You know, you let him know, yeah, for sure, it's a concussion. You know, that's usually all it takes. I've really run into very little problems with any coaches. Coaches are typically very supportive. But I think at the higher levels, you know, the big-time Division I schools, certainly the professional level, the dynamics may be a little different. Certainly most of what I see at the high school level, some college, mostly high school, coaches are very, very understanding, easy to deal with. And honestly, have very little interaction actually with the coaches. It's a rarity. Coaches and athletic directors and you know, high school administrators are becoming more and more aware of the fact that these things really need to be taken very seriously. We're starting to see lawsuits now. Kids who played high school, they've had several concussions. Perhaps those things weren't managed exactly the way they should be, or at least that's the perception of the family or the student, and now we're seeing lawsuits against coaches, lawsuits against schools, because concussions just weren't handled properly, and those kids have gone on to have what they feel are cognitive issues or learning issues or things of that nature. So coaches are pretty in tune with this and are being very careful. So their personal record and reputation is at stake. You know, if you're seeing their third stringer in the office, that's probably not a big deal. But if their star players coming in to see you, big games are coming up, that's a big deal for them. You know, that's something that they notice, and they typically have feelings about that. A sense of responsibility to the school, to the team, to the town. You know, they want to win, and they want their players to be out there, and their starters to perform well. Job security. At the high school level, this isn't as big a deal, but certainly, you know, the higher levels of college, and certainly in high school as well, I suppose. You know, if you're not winning, well, then your job may be in jeopardy. But if you're winning, things are good. So you want your players to play, especially the good players, and if they have a concussion and can't play, not thrilled about that. And future funding sometimes goes up and down with the wind. So it's another good reason why you want all your star players to play. So coaches have an interest in the outcomes of these medical visits for concussions as well. At the end of the day, the coaches, the trainers, the medical staff, the parents are hopefully all on the same team. Sometimes we have to brush all these things aside and just remember what the most important thing is. Whether it's a college athlete, professional athlete too, but certainly high school athletes, we want to just make sure they're safe, that their brain injury, their concussion is healed up, that they're normal, that things are clear, that the parents think they're fine, we think they're fine, they feel fine, that everything is okay before we let them play. Sometimes there's shoulder injuries, sometimes there's knee injuries, sometimes there's things that you can rush along, for lack of a better word, when certain circumstances dictate. But with concussions, you really want to treat them as textbook and as carefully as you can, and give them as much time as they need, and hopefully everybody on the treatment team understands that. So adverse outcomes in sports concussion. I think concussions are kind of like a number of things in American culture, like trans fats in food. Don't eat trans fats. Don't eat trans fats. Trans fats are bad. Don't eat trans fats. Now bags have 2 grams of trans fats or 1 gram of trans fats, and everyone's paying attention to trans fats. And then you ask, why do you care about trans fats? And no one knows. So concussions are kind of the same way. Concussions are on TV. Concussions are in magazines. Concussions are everywhere. Well, a concussion is a brain injury, and that's important, but what specifically are we protecting against, or what do we care about, or how come it's such a big deal now, or where did it come from? If you're going to talk to someone about concussions, then that's important to understand. So there's really 3 things. There's a lot of things. It's a brain injury, so that should be important enough, but there's 3 specific things that we're trying to protect against. The first, in the acute stage after concussion, is second impact syndrome. It's estimated to have up to 50% mortality. It is a condition where the blood flow in the brain is not properly being maintained. You have vascular dysregulation, which is improper blood flow maintenance after an initial insult. And a second insult, you get acute swelling of the brain. Sometimes that puts pressure on your brain stem. You stop breathing and you can die. This is extraordinarily rare. Extraordinarily rare. But it does happen. Finding reliable data on how often it happens, how many cases there have been, is difficult. But it is a real syndrome, and it is thought to result from early return to play. There is initial brain injury, it doesn't completely heal, and that player goes back, gets another insult to the head, and then this happens. So in the acute stages, this is the thing that we're most concerned about, that we're most trying to protect against. So there are several articles. There are ones more recent than this in 1996, but this is an interesting one to quote. Between 1980 and 1993, the National Center for Catastrophic Sports Injury in Chapel Hill identified 35 probable cases among American football players. 17 were confirmed with surgery and imaging. So they seem to go through great lengths to actually prove that this was second impact syndrome, and it was compelling. So this was one article that I felt was really pretty compelling. Post-concussive syndrome. So after the immediate return to play, once second impact syndrome is kind of off the table, which is a potentially lethal consequence of early return to play, then post-concussive syndrome becomes something that we kind of focus on, that we want to protect against. So this is a constellation of symptoms grouped into 3 categories. Physical symptoms, things you feel. Cognitive complaints, problems thinking or processing information. And behavioral or affective symptoms. I'm happy, I'm depressed, I'm hyper, I'm lethargic, things of that nature. Symptoms can persist from weeks to years. And although there's a lot of disagreement in the literature regarding how to diagnose it, it is a real syndrome, and I think it's more common than we know. It is in the DSM-IV manual, which is a manual that psychiatrists and psychologists use to diagnose psychological and psychiatric conditions. And you need to have a past head injury, and you need to have 3 of 8 symptoms for greater than 3 months. Headache, fatigue, sleep problems, personality changes, apathy, affective changes, irritability, and dizziness. You must also experience social problems and not carry a prior diagnosis inclusive of the above. So it's kind of complicated sometimes diagnosing somebody with this. Sometimes it's clear cut, sometimes not. If you have some irritability at baseline, you have a history of migraines, then you take a shot to the head and your symptoms are lingering, well, can we diagnose you with this? Well, you have a prior diagnosis of some of these other things. So do you have post-concussive syndrome? Do you not? Sometimes it's difficult. I've seen a fair number of these people, not as many in the sports realm as in the realm of more severe traumatic brain injury, and it's real. They take a shot to the head, the symptoms just never clear up, and 1 year, 2 years, 3 years down the road, they are being managed for headaches, dizziness, symptoms that they just can't pinpoint. I just don't feel like myself. I'm tired. I think Sidney Crosby probably would fit. I'm not familiar with the specifics of his case. He's a professional hockey player. He's had a couple of concussions. He's been battling these symptoms for a very long time. He recently tried to get back into hockey. He took another shot. Now he's back out. He would probably fit into this basket of post-concussive syndrome. This is tough. This is very debilitating. So what is it that we're concerned about? Well, they come in with symptoms. They go back to play too soon. They get another injury. Now their symptoms are hanging around. Now we take them out and we rest them, and the symptoms don't get better. And they can't tolerate school. Now they're on a homebound program. Now they're left back. They're repeating a year. Those effects, are long-lasting. If you go to college, you not go to college, how do you do in college, what job do you have, what can you do? So this is serious. So the most important thing to kind of avoid this is to rest them completely up front. They get an injury, if they can't tolerate school, or they don't feel like they can tolerate school, they're out of school. They're not playing sports, they're not playing video games, they're not doing stuff on the computer, reading, homework, anything. Their brains are completely rested. If you don't rest them up front, then sometimes these things can linger. It's unusual for them to linger months or years, but something that you could have wiped out in 7 days, maybe is going to be there for several weeks if you don't treat it seriously up front. So although the literature notes some rates as high as 30 to 80% in individuals with concussion, there's a lot of debate about the best way to truly diagnose a condition. It's influenced by a variety of things. The extent of the injury, how bad it was, pre-morbid coping style, which basically means if you're the type that has a splinter and is laid up at home from work because of it, or if you shrug that kind of stuff off and work unless you had a severed finger, those things can influence whether or not you have post-concussive syndrome. Prior head injuries, perception of blame, and gender. Perception of blame, you're playing sports, you get hit in the head, things tend to clear up. You walk through Walmart, you slip on the floor, those things could potentially linger. The person who slipped feels like that order shouldn't have been there. So chronic traumatic encephalopathy. Martland, in 1928, the person who described punch-drunk syndrome in professional boxers. It is also more formally referred to as chronic traumatic encephalopathy. The symptoms include motor problems, affective problems, personality problems, intention tremor, dysarthria, difficult time speaking, and emotional instability. It is associated with Parkinsonism and also more advanced psychiatric problems. So this is something that's down the road. I'm not going to see this, but I'm trying not to have the athletes that come through my clinic in a position where this is something they have to cope with. I don't typically expect it's something that the athletes I see will have to cope with, but every once in a while, one comes in, had a concussion, feeling good. Well, how many concussions have you had? Oh, this is my 7th. Okay, well, we might treat that a little differently. That's a heavy headache or a heavy concussive burden. So those are the kids that you worry about. Lots of repeated head injuries, what might happen to them down the road. So these are a few people from history that were punch-drunk syndrome sufferers, the most famous of which is probably Muhammad Ali. Lots of people think that's Parkinsonism, some think that's chronic traumatic encephalopathy is probably overlapping conditions. In recent years, attention has shifted to neurological injuries in other sports. Concussions have been catalyst to this. Chronic traumatic encephalopathy is not always associated with people who have clots, but is now something that we see in other athletes. Great attention is being focused on football players and the effects of repeated concussion. The first person to document chronic traumatic encephalopathy in a football player was Bennett Amalu, who was a coroner physician in San Joaquin, California. Iron Mike Webster played 17 seasons, spanning several decades in the NFL. He retired in 1990, and he died at the age of 50 in 2002. Dr. Amalu performed the autopsy. Heart attack was listed as the cause, but post-concussive syndrome was listed as a contributing factor. Examination of the brain revealed large collections of tau protein in dense tangles in the brain. These findings were published in Neurosurgery in 2005, and they elicited a flurry of controversy. As you might expect, when you have an NFL player who's had a lot of concussions, who developed post-concussive syndrome, and then that is listed as a potential contributing factor in his death, the NFL doesn't like to hear that. So one letter of opposition came from the NFL, and they demanded that that letter or that paper be retracted. Another letter of support that was published came from Robert Cantu. He's a sports neurologist who's been treating concussions for many years. And one of his patients was Chris Nowinski, who was a former high school and collegiate football player and subsequently a professional wrestler who had a lot of symptoms related to his concussions. Those three gentlemen, Amalu, Cantu, and Nowinski, began to collaborate on some studies. They founded an organization called the Sports Legacy Institute, and they have persuaded about 134 football players and other athletes to donate their brains to the Institute when they die. So far, the Institute has found pathology in a total of 12 brains, that may be higher now, because the slide is 2 months old, of former football players, as well as several wrestlers and soccer players, most of whom died in early death. This paper appeared in Science in 2009. It documents the Sports Legacy Institute, which gained national attention in the past few years. It's been featured in 60 Minutes. Also reports the work by Dr. Kevin Guskowitz at the Center for the Study of Retired Athletes at Chapel Hill. Dr. Guskowitz led a study of 2,500 former professional athletes and found that those who noted 3 or more concussions in their career were 5 times more likely to show signs of early cognitive impairment. In the same group, there was a relationship between the number of concussions and the presence of depression. So in folks that had 3 or more concussions, there is a dramatic increase in the future likelihood of cognitive impairment, how they think, what they can do, how they process information. And if you've had several more, well, now we're talking about behavioral problems, depression, and other things like that. So down the road, for the folks that have a lot of concussions, 3, 5, 8, 9, these are things that they may potentially have to deal with. Chronic traumatic encephalopathy in athletes, progressive tauopathy after repetitive head injury. This is a product of the Sports Legacy Institute. It provides a review of 48 cases of neuropathologically verified chronic traumatic encephalopathy in athletes to date. And it describes the gross and micropathology of chronic traumatic encephalopathy. So you have these athletes that have undergone, repeated head injury. And then they have post-concussive syndrome or other kinds of behavioral problems. Now they're deceased. You take their brains and you examine them, and they are very abnormal. They have these dense tangles of tau protein. The distribution of these dense tangles of tau protein are centered around the amygdala, the hippocampus, and the hypothalamus. These are areas that are thought to be the emotional brain that help you behave the way you do, act the way you do, create good mood, create bad mood. And later, Parkinson-like symptoms are thought to be associated with the generation of another part of the brain called the substantia nigra. So where do we go from here? Well, those are the 3 big things that we think about when we're trying to protect against problems in folks that have concussions. Second impact syndrome, post-concussive syndrome, and chronic traumatic encephalopathy. So that's why we care. So where do we go from here now that we know all that? Well, there's no way to predict who will get second impact syndrome, post-concussive syndrome, or chronic traumatic encephalopathy. There are some associations that we talked about. There are some developments on the horizon, like functional MRI, which may help us see some of these injuries. Right now, we can't see them very well on MRI, or at all on MRI, or on CT scan, or on X-rays, or blood tests. Functional MRI may prove to be something helpful with actually visualizing the injury. There are some genetic markers that are also associated with, that data isn't really firm reported. Overall, the only definitive recommendation is to be smart and be careful. If you, your athletes, your family members have symptoms that may be concussive-like after sustaining a head injury, they should see somebody who knows how to manage concussions. These are two professional football players. Troy Aikman is retired. He was an outstanding quarterback for the Dallas Cowboys, and he was basically driven out of the NFL in no small part due to his concussion. Troy Polamalu is still playing. He's had at least 7 concussions. And he's still playing on the Pittsburgh Steelers and playing very well. So time will tell. Hopefully he's fine as he grows a little older. So let's just talk about office management. Now I know the pre-office management's been addressed already by some of my colleagues today. I just want to mention a few quick things. So the pre-office timeline. Hopefully there was some neurocognitive testing that was done as a baseline test in some of the athletes. We do testing before the season starts so that if they get concussed, we can retest them. So hopefully that's taking place. Not always, but hopefully that's taking place. Then you have an injury. Remove that person from play, you do a sideline neurocognitive evaluation, and then invariably the parents, the relatives will come down and say, do we need to go to the hospital? Do we need to go to the hospital? The answer to that is usually no, you don't. Concussion doesn't need to go to the hospital. But I almost never say that. You almost never say that. When the parents come out of the stands, when the family members come out of the stands, and they are looking at you with that look like, he's not acting like himself, I'm worried about him, what should I do? And you say, well, I think it's a concussion. Concussion's something don't have to go to the emergency room and he should be fine, and check up on him every few hours. And they're looking at you kind of like, not really buying that. And then you say, well, you could take him to the hospital. So, yes, hospital, that's how. So if I get that look, like, I want to go to the hospital, then I say that. I say, it's probably a concussion. I think he'll be fine. There's really no need to go to the hospital. However, if it's not a concussion, it could be any of these other things. And I say all the big scary things. It could be a fracture of a facial bone, a skull fracture, a bleed in their brain. I can't guarantee you that he doesn't have those things. I don't think he does, but I can't guarantee it. And if it's a guarantee that you're looking for, then going to the hospital might be a good thing, if for no other reason than peace of mind. And then they typically package them up. They're done. So when they ask that question, should we go to the hospital? The real answer is no. They probably don't need to go to the hospital. But more often than not, I offer it to them, and if I feel like it's what they want to do, I recommend it. If for no other reason than peace of mind. Would never fault any other doctor for saying go to the hospital for a concussion, or a trainer for saying go to the hospital for a concussion. We say that there's no need to do it, but at the end of the day, when the parents are looking for a guarantee, this is my son or daughter who I love more than anything else, and they look pretty weird to me right now. Are you telling me that he's going to be okay overnight and he's completely fine, guaranteed? But you can't make that guarantee. So sometimes I just tell them to go. And it's never a wrong answer. It's a landmine. The trainers are in an incredibly difficult spot on the sidelines when they have to deal with this, and the physicians for that matter. I mean, you have a teenager that are all weird at baseline, regardless. They're all weird. They're all weird. And then you take that weird teenager and you put them in a game where circumstances are heightened, and adrenaline's pumping, and hormones are pumping, and they're sad, they're scared, they're angry, they're excited, and then you take that weird teenager in all those heightened circumstances and you give them a concussion, which affects how they think even more. And then on top of that, you're thinking about maybe they're keeping some stuff from me. And then in order to get a baseline idea of how Jimmy or Tammy or Susie is, you get the parents down for another opinion, And they're weird too. So you don't know. So the trainers are placed in an impossible position. I mean, an impossible position. It gets a little better in the office, but not much better. I mean, so when you are dealing with something that affects how your brain works, that you can't do a blood test or an x-ray or anything on, and it's in a teenager, and it's near a game, and the parents are there, and you can't rely on them, it is very difficult. It is very difficult to make a good decision. So let's talk a little bit about what we do in the office. The take-home messages. You have to understand the motivations of everyone involved, like we've talked about already. If there's any question, you remove them from play, you seek the advice of a specialist. Primary care sports medicine specialists are trained to understand and manage concussions. Be aware that returning to play prematurely or without proper documentation puts you and your patients at risk. You have to document everything. How they look, what they wear. When they come in sunglasses and they're staring at the floor, they're not talking to me, and mom said, well, that's just how he is. That all goes in the note. He's got sunglasses on, he looks bizarre, he's looking at the floor. I mean, all that stuff matters. It all matters ultimately. Protect your athletes, that's the most important thing. Protect yourself. Be very conservative, err on the side of caution. When you have that weird teenager and he's in the game and you don't know what's happening, err on the side of caution. Take them out, rest them, send them to a specialist. Base what you do on a standard of care. You don't look at one guy and say, he should be good, and then another guy and say, well, I'm just not thinking he's good. There has to be a standard. If you don't base what you're doing on a standard of care, then you're going to be in trouble. For those who are interested, this is more or less the standard of care, at least that we use in our concussion center. This is available really for free on the internet. They have it on a variety of sites. It's the consensus statement on concussion in sport, the 3rd International Conference on Concussion in Sport. It was in Zurich in 2008. It comes out every couple of years. And this kind of outlines how we manage concussion. We deviate from this, but in general, this is the standard, I would say, more or less the standard of care for concussion management. So in the office, there's a physician evaluation that happens within 1 to 3 days of the injury, with hopefully repeat neurocognitive testing. Ideally, they had tests before the season started, when they were normal, or as normal as they're going to be. Trained staff monitors the athlete for symptoms. If asymptomatic, they feel fine, and they begin to progress through a return to play protocol. They start jogging, and the next day they do some sprinting, and then the next day they do some drills, and so on, for about 4 or 5 days until they're ready for contact. If the athlete develops any symptoms at any stage, they stop and they start over with the progression. Prior to the contact phase, for soccer, or football, or contact sports, the athlete comes back. A complete second post-injury assessment is done in the office. A satisfactory recovery on neurocognitive testing, and there's normal clinical exam. Then you may put them into contact and return to play. So the return to play decision, that's kind of the point where you take everything in and everything that's happened and how are they doing, and you decide, am I going to let this guy go? And is he ready to go back to sports? I think it's important to share in that decision. I think a lot of the athletes and the families that come in, they say, well, we're going to go see the doctor, and then the doctor's going to say, yes, you can play or no, you can't, and then that's what we're going to do. And that's not an altogether unreasonable way to look at things, but I like to put some of the onus on the family and on the athlete. I like to have them share in that decision. I don't ever say, you're ready for football, so go play football. I don't ever recommend anyone play football, or any sport for that matter. You know, once we get to a point where things are good, and your testing's normal, and your exam looks good, and everything looks fine, then I say, usually, you are as medically safe now as I think you're going to be. So if you want to go play sports, I think that's okay if that's the decision that you and your family are leaning towards. And then they look at me like, what does that mean? And I say, well, you know, risks include all the following things. You could hurt your knee, you could hurt your neck, you could have another brain injury, all these things, second impact syndrome, you know, chronic traumatic encephalopathy, you know, these things are all potential risks. I think they're highly unlikely, but they're risks. So you take on some risk when you return to sports. And if that's the right decision for you, then return to sports. And I'm very upfront with them. I say, okay, my job is to just scare you and say all the horrible, scary things, just so that you know all the facts, and then you make an educated decision about, what's best for you. You make them understand that returning to sports carries risk. Make the risk known, document everything. So quickly, I'm just going to go through, what do we do as a clinical exam? Their appearance, their disposition, their demeanor. Like I said, when they walk in, they're staring at the ground, they have sunglasses on, they're talking to you, that's important. Even if everything else is normal, that's important. And if mom says that's how he always is, well, then the problem might not be a concussion, it might be another problem. Cranial nerve exam, all the important nerves that we want to test from in and around the brain are important to assess. That if there's something wrong with the brain, you can find abnormalities there. Strength, sensation, proprioception, where things are in space, balance, these are all things that the brain has a lot of influence over. And a musculoskeletal exam. It's always important to check the neck. Anything that provides a bad enough impact to give someone a concussion can theoretically give a bad neck injury. So 1 out of every 10 or so concussions I see, do you have neck pain? Yeah, my neck hurts. No one really talked to them about that or examined that or mentioned that. So you always want to check the neck in addition to the rest of their joints. The SCAT-2 is a neurocognitive test. It checks for symptoms, basic baseline brain functions, orientation, memory, concentration, balance, coordination. We do this in the office. We also do it on the sideline. It is imperfect, but it's useful. It's useful. The impact test. This is the test you hear about on the news, and Dick's Sporting Goods can help you get one of these tests. And, we offer these tests at our clinic. We use these tests at our clinic. They are a useful tool, but they are just a tool. They are a piece of the pie, and they're not a gigantic piece of the pie. They are a moderate-sized piece of the pie. The most important things are how they look, how they act, how they feel, what their clinical exam looks like. This test is really bizarre. I mean, it's not like anything else these kids have ever taken. And if they are not extraordinarily bright, if they have mood disorders or cognitive disorders or attention deficit disorder or any number of things, it can really affect how they do in the test. If they know that their baseline test is going to be compared to their post-concussion test, some people feel as though they might really do poorly on the baseline test. So if they're concussed later down the road and take the test again and do poorly, well, then it doesn't look so bad. They don't look concussed because they did so badly up front. Sometimes there's ways to tease out whether or not they did bad intentionally, but sometimes not. I've seen a fair number of people who have okay scores at baseline, and then they get concussed. And these are, very, you get the impression, very honest, forthcoming family, forthcoming kid. They take the test, and the tests are fantastic. I mean, almost as though the concussion, knocked something into place. It's not, they try very hard on the baseline, I think, and they try very hard on the test after they got a concussion. But for whatever reason, they just did a whole lot better. And you see it both ways. You see kids that get dramatically better. They feel great. They felt great for weeks. And they keep bombing the test. And then other kids, they do okay the first time. They take the test and they feel horrible. And they ace it. They do fantastic on the test. So a lot of things have to be considered with this test. It is imperfect, and it's only a small piece of the pie, but it is an important piece. It's just a tool. It's not a test for diagnosis. It's not a yes or no. So when someone's going, on ESPN, I remember when Tim Tebow had his concussion, the concussion test. He passed his test. And so everyone who knows something about concussion heard that and said, oh, it's not a pass or fail test. It's not like a blood test. It's not a pass or fail test. So it's just a tool. It helps, but it's not a yes or no. So in summary, be aware of underreporting and the biases and motivations of the teams, coaches, and trainers, as well as the players. Provide education to athletes and families about the serious nature of concussion. Be very cautious with regard to returning athletes to play following a concussion. Always make sure to know your athlete's complete concussion history. I had a kid in my fellowship training who came in and he took an elbow to the head. He was a basketball player, and I watched him for about a week, and he got bounced back and felt have him? And I said, sure. I came back into the office and we were talking. And when I saw him initially, I didn't ask him how many concussions he had had previously, which was an error. And we're talking, and he said, you know, same thing happened to me after my 6th concussion. Yeah, I had these kind of lingering headaches, and what number is this? You know, this is, you know, Mom's sitting here, Johnny's had a lot of concussions. He had like 10 or 12 concussions. And so this is someone I saw, work him up, let him lose. There should have been a whole lot more discussion, about should we play sports, what else do we need to do, we're going to rest this for longer, you're out for the season, than just a week of rest and back to sports. So when a kid gets a concussion, a real important question is to ask how many other concussions have you had. And protect yourself. Always make sure to document everything. If you don't know what you're doing, or you don't know if you have a concussion, make sure you get them to someone who knows. Primary care sports medicine doctors are excellent. Neurologists are great. There are a lot of doctors that treat concussions quite well. Primary care sports medicine doctors are trained in concussion management. Thank you so much for having me here. I really appreciate the opportunity to talk to all of you. I'm sorry I probably ran over, I don't know what watch on, but I probably ran over a little. If anyone has any questions, I'm happy to answer. Or not. Yes. Yeah. Yeah.
And that there are other tests available.
I think the impact is the most thorough. It has the most research behind it with regard to validity. There are a few other lesser known tests, but as far as we were concerned, that one has the most research backing it up. So that's the one that we chose to go with. Yeah.
Soccer and hitting the ball.
Yeah.
Do you see a lot from that? Or
I'm trying to think if I've ever seen an actual concussion from heading a ball. I don't think that I have. I've seen players come in with headache issues after drills, you know, they're having headaches for the last few weeks. Well, what happened? Well, nothing. And then Mom chimes in and says, well, he was out at soccer practice and they were heading balls for an hour and a half. You know, I think that there's something to be learned there. I think that it's not good. I think that it should remain part of the game, but in terms of drills and excessive heading of a soccer ball, I probably would recommend, not doing that. I think in future, years, in 5 years, 10 years down the road, we might know a whole lot more about that. Yeah.
Do you guys know soccer players who've had either one or multiple concussions in soccer or recommend that?
If they've had a whole lot of concussions, then sometimes. I can't think of someone that I've seen, a soccer player that I've seen that's had so many concussions that I recommended that. I had a family ask about that, and I pointed them in the right direction. If I had a soccer player with 3 or 4 concussions, and they wanted to go back to play, then yeah, I would probably recommend it. Ideally, that person would sit out for a while, might consider another sport, once you get up around the 3, 4, 5 concussions, but I think it would be nothing but help. So yeah, I can do that direction. Yes?
We had a soccer player who had multiple concussions, and then we started requiring her to wear the headgear. Does that make a difference? Is it kind of like the football helmet that is kind of...
I think there's some research that supports some football helmets being a little more concussion resistant than others. With regard to soccer headgear, I'm not familiar with any actual research or data that says that one type of headgear is better than another, or that one particular type of soccer-specific headgear drastically reduces the likelihood of a concussion. I don't think it could hurt. So I think any additional cushioning or protection you have around the head, if you have multiple concussions, it can only help. Yeah?
Is there a propensity for concussions perhaps in some people that would be greater than others? Like you may see 2 guys, right? And maybe they bang heads, right? You get essentially the same force.
Yeah.
One ends up with a concussion, the other doesn't, and they say hard-headed. Or 2 kids hit the ground. One fairly soft, hits the elbow in the head, he's concussed. The kid that smacks it, again, you'll feel so, the brain inside the cranial cavity or whatever.
Yeah.
The intensity that you guys are seeing in research.
You know, of all the parts of the body, the brain is probably the least well understood, and why one person, you know, with a similar impact would get concussive symptoms and the other wouldn't. That's tough to explain. When the kids come in, or you know, athletes come in, my spiel usually says, you know, once you have one concussion, you are more likely to have others. The symptoms are likely to be longer lasting. They're likely to be more severe. So with regard to why one person might have an injury and one person may not, the person who got injured, their threshold may be lower, perhaps, from a prior injury. There's also genetic markers that we're going to find now that some folks that get concussions have, that folks that get less or no concussions don't have. That's, you know, that's really in its infancy, that type of research. But why a brain behaves one way in one person and another way in another person is something that I think we still don't thoroughly understand. Yes, Jane.
How do I don't want to use the word argue, but the parent takes the kids to the hospital, the CT scan, and the whole shebang, they go, they're fine, and the kids, you know, looking at you with scrambled eggs, but they've got the negative CAT scan, so my son and daughter can play. What do I do, lay behind the car tire?
Well, I typically say, you know, here's the CAT scan of his head, and this CAT scan shows that his head and his brain are completely normal. And that's what I would expect, because a CAT scan can't see a concussion. So it means nothing. It means nothing. You know, the CAT scan was good at making sure that he didn't have any broken bones. The CAT scan was good to make sure he didn't have a bleed in his head, which is very important. But a CAT scan does not show anything about a concussion. An MRI doesn't, an X-ray doesn't, a blood test doesn't. So it is very valuable that he got this CT scan, and I think it was appropriate to bring him there. I think it was appropriate to get this scan, and that was good judgment on your part, Mom, but it helped us know that there's no bleed. It helped us know that nothing's broken, thank God, but it would not pick up a concussion. It gives me zero information about a concussion. So that's sometimes what I do when they come in with the imaging studies and they say, it's fine, it's fine. You just say, well, these imaging studies don't see concussion. So, I mean, that's how I would argue. And if they're obviously forked out, well, then you would hope you had another, you know, another good point to discuss with Mom. You know, look at him. Obviously not normal. Yeah.
Is a concussion a bruise?
Well,
You said you was that.
yeah, I say bruise. Is it a bruise? I think it's a bruise. Really, it's a dysregulation. It's a functional difference in how the brain works, how it metabolizes energy and sugar and the blood supply to that part of the brain. That's the best way to describe it. And when I say that in clinic, I usually get like, so I say bruise. It's a bruise. It's a brain bruise, and everybody seems to glob on that. Is it technically, really specifically a bruise? Well, I don't know if that's the best way to describe it, but that seems to be the way that folks understand it best. Thank you so much for having me. I'm going to hang out for a few minutes if anyone else has questions. Thank you.